Good evening to all. I think welcome you all to this June edition of Tamil Nadu ISG monthly meeting. I think today we have a packed program. Again, first part will be postgraduate session, followed by two talks on some topics which are not usually commonly discussed in our club, in our meetings. To start off, I will request Dr. Epan, who was president at Tamil Nadu ISG, who has kindly come over from Vellore to preside over the meeting. I request him to give us welcome address, please. Thank you.
Thank you, Parama. And dear friends, so welcome to this month's TNISG monthly meeting. And I'm sure the hall will fill up, but Dr. KRP has allowed 5 minutes delay in starting, so we are about to start. I like showing cartoons, so let me show a few minutes of some cartoons. So can I put that thing on? I try to use cartoons to explain something which I can't study well. I'm hypothesizing something, and I may say these cartoons speak to me a lot. So it may do to you as well. So the topic is around, I'll take 2-3 minutes, is around acute liver failure. Let's say a person consumes poison, or somebody poisons somebody else. Did the poison kill the person? Or did my body response to the poison kill the person? So it's around that topic. It's on liver fenestrae in cartoons. So as you know, in the liver sinusoid, the endothelial cells have got holes in them called fenestrae, through which this two-way traffic of fluid happens into the space of Deci. And if these get blocked, the liver cell will go into failure, hepatocyte failure. To me, I think that is one key component of acute liver failure, and that's what gets improved by this treatment of plasma exchange. So, what happens if a poison reaches this area? So, cartoons. So long ago there was this Western movies and all. So what happened? What does the public do when one enemy attacks? So they'll probably close the shutters in the window. And this is one famous children's movie, so called Chitty Chitty Bang Bang. Some of you may have seen it. It's highly recommended for children. So what happens when this chap who comes to catch the children comes? So all the houses will close their doors and windows. Okay, it's an immediate response. In Sholay, what happens when the dacoits come to the village? The streets are deserted. That street picture is from a Band in Kerala. It's not from Sholay, but everywhere they close the doors and windows. What happens if a bank is robbed? The teller probably will close the window. So, in the liver sinusoid, these fenestrae, which need electron microscopy to see, so it's beyond our usual way of, we can only hypothesize, okay, what will be happening. So when you ask the question, do these close? So there have been studies specifically looking at these, and these are some features differentiating yet another endothelium which has got fenestrae in it, which is in the renal glomerulus. That also got fenestrae. The two differences are, the renal glomerulus has got a basement membrane. The liver doesn't have. It allows free transfer. As well as it seems to have a layer on top of the endothelial cell called glycocalyx. These two are missing in the liver. So liver is very porous. If a poison comes, it can, freely nutrients go either way, but poison substance also. So will it close the shutter? So here is the study. Now that we have a question, let's see what the study showed. So the study showed that yes, it does. In 1995, they used some technique of in vitro studying this. And for example, on adding serotonin, this fenestrae become smaller in size. On tracking, using some fancy techniques, tracking the fenestrae dynamics, they could show that the sieve plates open and close within few minutes to 2 hours. So what we saw in the cartoons and movies seems to be true here as well. So immediate response is we close. But when we close, the problem is that the flow of nutrients stop. So I get liver failure. So that is one component of it. I won't go into that. So that's right. So when the enemy attacks, as I showed in the cartoons, Dr. Jayanti ma'am, I've just used some cartoons to show some new concept. The windows are closed. The chateaus are closed. So what do we gain? The poison is kept out. What do we lose? What we lose is the normal function of the liver is lost. And we recognize it as acute liver failure. And that is the area where new treatments can get targeted. So thank you. That was just a small cartoon introduction to another topic. So maybe I'll request Pirma to roll the actual program.
Thank you, sir. Even the cartoons have a lot of science. Thank you so much, sir. Now, we'll start the main postgraduate session. I'll request the chairpersons to come over and conduct the proceedings. Dr. Hema Vijayalakshmi, Dr. Manimaran, Dr. Vadivel Kumaran, please. And Dr. Revati, I think Madam will be joining shortly, please. And I request the postgraduates to stick to time. Each presentation will be for about 15 minutes. So you'll have around 12 minutes for presentation and 3 for questions, please. Yeah, sure.
Good evening to all. I thank you all for coming today on a busy Saturday evening and taking your valuable time to attend this meeting. And now we'll start the PG session. And the first topic today will be, it takes some time to understand the topic, so please bear with me. It's called An Unusual Synergy with Depleting Energy, presented by Dr. Deepa from Children's Hospital, Egmore. And I hope she explains it and makes me understand better.
Good evening, one and all. I'd like to thank my professors and organizing committee for giving me an opportunity to present this case, An Unusual Synergy with Depleting Energy, from the Department of Pediatric Gastroenterology, with the mentorship of Professor Dr. Nirmala ma'am. Here we present a case of 12-year-old male child who is a third-born male child of third-degree consanguineous marriage, who presented with abdominal distension, abdominal pain and vomiting for 3 months, and high-colored urine and yellowish discoloration of eyes for 1 week, and giddiness, headache and fever for 1 day. The abdominal pain, history of abdominal distension for 3 months. He had an insidious onset, progressive in nature, which was a uniform abdominal distension, and abdominal pain. It was a diffuse dull aching abdominal pain without any association of food intake, vomiting 3 to 4 times per day, non-bilious, no history of any hematemesis. He did not have any decreased urine output or early morning facial puffiness. He did not have any breathlessness, orthopnea, chest pain or palpitation. No history of any diarrhea. He had history of easy fatigability. No history of melena or bleeding manifestations. No history of altered sleep pattern or altered behavior or seizures. No history of any clumsiness of movements or involuntary movements or worsening of handwriting or deteriorating school performance. He did not have any itching or rashes. He did not have any history of previous blood transfusions, nor had any history of any drug intake or intake of native medicine. Antenatal history was uneventful. He was born out of full-term normal vaginal delivery with a birth weight of 2.5 kg. He cried immediately after birth without any history of any neonatal jaundice, without any history of NICU admissions. He was a developmentally normal child. Before the illness, he was studying in 6th standard, and his scholastic performance was satisfactory preceding the illness. Family history: he was born out of third-degree consanguineous marriage. His elder brother died at 1.5 years of age in 2007 due to an unknown cause of jaundice. They don't know what is the cause. And his father and his second elder brother died around 6 to 8 months back due to drowning. That was an accidental drowning. And he is the only surviving child for the mother. And coming to the anthropometry, his weight is 28.2 kg with a height of 144 centimeter, BMI being 13.4, falling under underweight. His general examination was, he had icterus and bilateral pedal edema. Otherwise, his general examination was unremarkable. He did not have any KF ring. Vitals were stable. And his per-abdominal examination, abdomen was distended, not warm and not tender. Shifting dullness was present without any organomegaly or any dilated veins. Other system examination, cardiovascular system, respiratory system and CNS was normal. Coming to the investigations, he had a mild increase in bilirubin and AST with 78, and a mild increase in SAP and GGT, and hypoalbuminemia 2.7, and increase in INR 2.5, and mild elevation of ammonia. As he had ascites, we proceeded on with ascitic fluid analysis. He had a high SAG, low protein ascites. The SAG was 2.3. So high SAG, low protein ascites, the most common causes are cirrhosis. So we had a diagnosis of decompensated chronic liver disease in hand, with the first differential diagnosis of Wilson, as he had born out of third-degree consanguineous marriage and the most common age presentation. And the second common cause is, second DD was infection, third DD was autoimmune disease, fourth is drug-induced, but he denied any history of drug intake or native medicine, and the fifth one being the other hereditary causes. So we proceeded on with other investigations. Ultrasound abdomen revealed coarse liver echoes with surface nodularity and splenomegaly, with an impression of chronic liver disease with cirrhosis with portal hypertension. His viral markers turned out to be negative for hepatitis B and C and HIV. Wilson workup was also negative. A slit lamp examination revealed no KF ring with a normal serum ceruloplasmin and normal 24 hours urinary copper. Autoimmune workup was also negative, with all the ANA, LKM and ASMA was negative. We proceeded on with UGI-scopy, which revealed grade 2 and 3 esophageal varices with congestive gastropathy suggestive of portal hypertension. So at this point of time, we had a diagnosis of a decompensated liver disease in hand, but from the workup, we know that we ruled out Wilson, we ruled out infection, we ruled out autoimmune, and no history of any drug intake or native medicine. And finally, we were left out only with other hereditary causes. But at that point of time, I already told that the mother had suffered a loss of 2 persons in home, and she was not ready to stay long in our unit. So we did not proceed with any liver biopsy or any other test. And they were hailing from Andhra, so we did not have any CMC card to do any other investigations for them. So we listed the child for liver transplant in Stanley with the symptomatic management. All his ascites had been resolved with all the managements. We listed in Stanley, and the child was kept under follow-up. Our mission to diagnose the cause of chronic liver disease was still there, but with an interval. But we never knew that Tiger was approaching us in the second admission so that it will hit us back. After 15 days of discharge, the child presented again to us with abdominal distension for 3 days, abdominal pain for 3 days, vomiting, pedal edema for 1 day, but altered sensorium, lethargy and refusal of feeds was also present, with a classical history of weakness of right upper limb and lower limb with deviation of angle of mouth to right side. His other systemic examination, CVS and RS was normal. His final diagnosis, he had a drowsy, irritable stage with altered sleep pattern and slurred speech. So, final diagnosis of DCLT, portal hypertension with hepatic encephalopathy grade 1 and right hemiparesis with left UM and facial palsy was made. It is a unusual association of right hemiparesis with left UM and facial palsy. So a non-vascular territory was thought of. So we thought of a metabolic cause for stroke and we proceeded with the investigations. Serum lactate was elevated, which found out to be 50, and serum ammonia was also elevated. Child facial asymmetry and encephalopathy resolved in 2 days, but the right hemiparesis was persisting. On further examination after the encephalopathy, we were able to find there was bipyramidal signs and bilateral partial ptosis without any diurnal variation, and the pupillar reaction was normal and EOM was full. We could see that in both upper and lower limbs of both right and left side, there was a diffuse increase in tone. So we thought of a non-vascular territory on neurological opinion for the stroke, and we proceeded with MRI brain as suggested by the neurologist. We took an MRI. Here we could see there is diffuse hyperintensities of the T2, weighted images of the cerebellum and the periventricular regions and subcortical white matters of the parietal, occipital, all the areas, and there is diffusion restriction of all the areas. Which gave us a picture of mitochondrial leukoencephalopathy. So we proceeded with CPK, which was normal. AFP was 36.9, which was also normal. And fundus, there was a mild temporal pallor, which was more on the left side than on the right side. And EEG showed diffuse slowing. With all this in hand, we had the diagnosis of chronic liver disease with a metabolic stroke. Query optic atrophy could be explained by the temporal pallor, and central ptosis, query myopathy. We were not able to check any other than CPK. We were not able to proceed with any biopsy. So with all this in hand, we had a cluster of chronic liver disease and the metabolic stroke, which also involves the CNS. So mitochondrial hepatopathies, since it was a multi-system involvement, mitochondrial hepatopathies was thought of. Mitochondrial cause of hepatopathy and leukoencephalopathy was thought of. So A+ syndrome, it presents early. We had the differential diagnosis of A+ syndrome, hepatocerebral mitochondrial DNA depletion syndrome, succinyl-CoA ligase, benign reversible mitochondrial hepatopathy, complex 3 deficiency, Gressel syndrome, Mechdel syndrome, TRMU deficiency, and MELAS only for stroke, not for hepatopathies. A+ syndrome, it presents in the early age group, and it also has seizures. In our child, cortical involvement was not there, and there was no seizures. In hepatocerebral MDDS, that is mitochondrial DNA depletion syndrome, it presents with liver failure, chronic liver disease, and peripheral neuropathy. Plus or minus, it was somewhere fitting into this. And succinyl-CoA ligase deficiency, it has tubular defects that and the encephalopathy like picture, which was not there because the encephalopathy reversed immediately within 2 days. That was also only hepatic encephalopathy, not mitochondrial. We could not explain that encephalopathy for mitochondrial purpose. And benign reversible mitochondrial hepatopathy, since the name suggests, it was not reversible. And complex 3 deficiency, it will be associated with renal manifestations. Gressel syndrome, as the name suggests, growth retardation. The child did not have any growth retardation till the age of presentation. And cholestasis was also not present, and encephalopathy was also not present. In Mechdel syndrome, again, there was no encephalopathy, and TRMU deficiency, it also presents with seizures and encephalopathy in an earlier age group. MELAS, though neurologist team thought of MELAS, the association MELAS, that is, it will be usually involving the occipital, parietal and temporal regions. But here it was diffuse involvement, and also the brainstem involvement was also there. So the final diagnosis which we thought of was hepatocerebral mitochondrial DNA depletion syndrome. We proceeded with the whole exome sequencing and mitochondrial DNA sequencing. Here it revealed MPV17 gene defect, which reveal mitochondrial DNA depletion syndrome 6. It is a form of hepatocerebral mitochondrial DNA depletion syndrome. So the title being unusual synergy and with a depleted energy. Mitochondria is the storehouse of energy, we all know, so it is a depleting energy. Coming to the discussion, mitochondrial DNA depletion syndrome is a mitochondrial DNA maintenance defect. Over 1,000 proteins are needed for the structure and function of normal mitochondria. Mitochondria are under dual genome control, with the mitochondrial DNA encoding a very small fraction of mitochondrial proteins, while the vast majority of mitochondrial proteins are encoded by the nuclear DNA. In contrast to nuclear DNA, which replicates only during cell division, mitochondrial DNA synthesis is continuous throughout the cell cycle. Depending upon the cell type, a certain copy of mitochondrial DNA is required for the production of adequate mitochondrial DNA encoded proteins. So in hepatic and brain, it will be more concentrated. Defects in any of the proteins involved in mitochondrial maintenance can result in impaired mitochondrial synthesis, leading to either quantitative or qualitative defect. The quantitative defect is being mitochondrial DNA depletion. MPV17 is one of the mitochondrial DNA maintenance proteins. Mitochondria, it is located in the mitochondrial inner membrane, involved in importing deoxynucleotides into the mitochondria. This paper by Ayman, who did a work on MPV17 related mitochondrial DNA maintenance defect, he reported the new cases and review of clinical, biochemical and molecular aspects. In that paper, it was said that mitochondrial 17 related encephalopathy typically has an early onset, because only 100 cases were reported till that paper in the review of literature. In that case, around 96 cases presented in the early infancy. That is within 30 days. In the neonatal period, around 36 cases presented. After that, 56 cases are presented in the infancy, that is 1 month to 12 months. Only 4 cases are presented in the later period. It is an emerging rare phenotype associated with biallelic MPV17 pathogenic variants. It's a neuromyopathic disease. Has been described in 4% of individuals. That is only 4 cases throughout the world till that paper. It was a 2018 paper. This disease is of late onset and characterized by myopathy and neuropathy. In those 4 individuals, 1 individual presented during childhood, 2 during adolescence, and 1 during adulthood. All the 4 individuals had myopathy and peripheral neuropathy. Here this child, our child did not have any peripheral neuropathy. Liver manifestations were absent in 2 individuals. Of the 4, liver manifestations were absent in 2 individuals in that paper, and other 2 had minor liver involvement without any liver failure. In our child, we have liver failure without any peripheral neuropathy and later onset. So it is a new variant. And metabolic derangements being hypoglycemia and lactic acidosis. So total cases are reported till date for this mutation, that is C293, is 2 homozygous and 10 heterozygous. Ours is the 3rd homozygous case to our knowledge. And coming to what next? If we had already told that we had listed the case for liver transplant, but what could have happened if the child had already been into liver transplant? This paper shows that what is the good news is in MPV 17 defect of mitochondrial DNA depletion syndrome 6, there is a good C293. If before liver transplantation is done before the neurological onset, it is a milder phenotype, and there can be some good prognosis for this children. But our children, but in our child, the neurological manifestation has set in within 15 days of onset of the acute liver failure, acute and chronic liver failure. So we manage the child with woodcast, spironolactone, and propranolol, and mitochondrial cocktail therapy and physiotherapy. What is the newer modality of treatment? It is in under studies. Adenovirus associated virus vector-based gene therapy for mitochondrial disease for mitochondrial DNA depletion syndrome is under track. Treatment after beginning ketogenic diet improved liver phenotype. Treatment prior to ketogenic diet prevented further liver damage. That is the recent advancement. And here are my references. So what is the lesson learned from this case? Unless we have a confident diagnosis or the confident cause for chronic liver disease in children, think twice before sending the child to liver transplant. And if there is a multi-system involvement without any known cause, because in literature it says that cryptogenic cause of cirrhosis or chronic liver disease, most of them are replaced by mitochondrial causes nowadays. So if there is a multi-system involvement, we can think that mitochondrial disease can be taken into account. Thank you.
Good evening, professors, my colleagues and friends, students. It's a great pleasure for me to be the part of this program. On behalf of the other chairpersons, I thank TNISG for the opportunity. Coming to the topic, what is the synergy here?
Ma'am, it was a metabolic stroke with chronic liver disease. That is the synergy. He had myopathic features also like ptosis. Though we were not able to prove, even though if metabolic stroke with chronic liver disease was thought of, it should have been in the early infantile period for considering it as a mitochondrial cause of chronic liver disease with CNS involvement, ma'am. Only 4 cases. So it is a very, very rare cause we could have kept because it is a later onset.
Excellent presentation.
Thank you.
I think here the family history plays a major role because the father died of drowning, another sibling died of drowning.
Sir,
so it could be still a
same
part of the
time-
myopathy. So that indicates some kind of myopathy would have been there in those individuals that could have led on to a drowning during the process of swimming. That's another clue here. That plays a major role in eliciting a proper family history also here. Maybe.
No, they were absolutely normal. This child was also absolutely normal, and mitochondrial DNA depletion syndrome is an autosomal recessive form of inheritance. So the
So complete
father
mutation is going to be there.
maybe
All children is going to be affected.
yes, the father they died in accidental drowning when they were.
That's what. So
yes, sir.
2 people dying of drowning in the same family, it could be an accidental for a commoner, but for us, with the retrospective, when you're thinking about
Yes,
it,
sir.
so there could have been a possibility of myopathy in those individuals also that could have led on to the drowning there.
Yes, sir.
Again.
Yes, sir. Yes, sir.
That could be again a mitochondrial
Yes.
defect or mitochondrial myopathy would have been there. A minor form of variant could be there. They would have presented at various ages.
Yes, yes, sir.
That's a very nice case work.
Yes, sir.
And thank you for enlightening us of another cause of where you can have a CNS involvement and a liver involvement, because whenever we see a CNS and a liver involvement, we have very specific sets of diseases. We just look for complications of liver disease or encephalopathy, or then the other thing is Vincent's disease. That's the commonest thing. Then beyond that, we are forced to do some literature search and things. So this you have highlighted something extra. So next time we'll keep it in mind.
Should we send these patients for liver transplant as such? Because they could still have other manifestations like myopathies and other things.
No,
Is it-
sir.
I think
In
this is
literature
not-
does not recommend them to be listed
So
for
got to
liver
be very
transplants.
cautious about referring these patients, these kind of individuals, when you have a proper diagnosis.
In literature, but that is the only option available for the child. But anyway, we have to wait. We have to wait and see. In the CNS part of it is now he is crippled. The CNS part of it is progressing. That's why we have not we have listed him, but we have not progressing with the proceeding to transplant as of now. Mainly presented to highlight that before going for a transplant, better get a diagnosis for any liver disease in children. Actually, the child had ascites at that time. That's why we postponed. We thought when he comes back, we do the transplant. So we thought that time he presented with CNS. When he presented with CNS problem, immediately we did a gene testing. When the gene test came, then we didn't want to proceed with the biopsy again. Actually, ideally we should have done a biopsy first. Liver biopsy, maybe it will show only cirrhosis. I don't think this got any specific features for mitochondrial. Yes.
Thank you. With this, we close the first talk, and we can go to the next talk. This is by topic is revisiting uncommon cause of common symptoms, presented by Dr. Adit Aslam from DDHD.
Good evening, all. My name is Dr. Adip. I'm a first year DM postgraduate from Department of Digestive Health and Diseases, Kilpauk Medical College, and I'll be presenting. Today I'll be revisiting an uncommon cause of a common symptom. So 28-year-old female, Ms. Y, presented to the hospital OPD with chief complaints of yellowish discoloration of her eyes for the past 1 week. History of presenting illness. The patient was apparently normal 1 week back, following which she developed history of yellowish discoloration of her sclera for the past 1 week, which was insidious in onset. It was non-progressive and associated with high-colored urine. She did not have any symptoms, prodromal symptoms. She did not have any symptoms of cholestasis. There were no symptoms of decompensation. Also, there were no history of any tremor, dysarthria, ataxia, and there was no high-risk sexual behavior or history of any recent travel. Past history. The patient tells that she had recurrent episodes of jaundice since the first decade of her life, which was noticed by her family members, with no prodromal symptoms. There were no cholestatic features or any features of decompensation. She was managed in local hospitals, but with no medical records available. And the patient also tells that there were a history of CAM intake after each episodes of jaundice. There were no history of surgeries in the past, with no history of blood transfusion, and there is no patient is not a known case of systemic hypertension, diabetes, hypothyroid, or any past history of tuberculosis is present. Personal history: there are no addictions and there is no high-risk sexual behavior. Birth and developmental history was normal. She is a firstborn child of non-consanguineous marriage, born by full-term normal vaginal delivery. There is no history of any neonatal jaundice, and there is satisfactory social and academic performances in school. And menstrual history is also normal. Family history: both mother and father are healthy. She has a sibling. He is also born healthy, and there are no similar episodes in family members. Summary: 28-year-old female with recurrent episodes of hepatocellular jaundice, without any prodromal symptoms, with no features of liver decompensation. So my syndromic diagnosis was recurrent hepatocellular jaundice, and the differential diagnosis that I considered were congenital hyperbilirubinemia, Wilson's disease, and also autoimmune hepatitis, though the chances are very less likely. General examination: she was normally built and nourished. There were no signs of liver cell failure except icterus. She was not pale, no cyanosis, clubbing, pill edema, or lymphadenopathy, and scratch marks. Vitals were all normal. Pulse was 80 per minute. BP was 110/80 millimeters of mercury in right upper limb in supine position. Saturation was normal, and she was afebrile. Abdominal examination was also normal. There was no organomegaly. Other system examinations were normal. Again, the differential diagnosis was congenital hyperbilirubinemia with less chances of other DDs like Wilson and autoimmune hepatitis. Coming to investigations, her hemoglobin was 12.5. CBC was normal actually. Total count was 7,600 with platelet count was 2.07 lakhs. Renal function test, urea and creatinine were normal. LFT, total bilirubin was 5.6 with direct fraction of 3.6 and indirect fraction of 2. All other liver enzymes were normal. Prothrombin time and INR was normal. Coombs test was done, which was negative. Peripheral smear and reticulocyte count was normal. Viral markers all were negative. Serum ceruloplasmin is also done, which was normal. Ultrasound abdomen and pelvis was normal. Fibroscan was 5.3 kilopascals. There was no evidence of any KF-ring in ophthalmological evaluation. And autoimmune workup was also done, which was also negative. So we proceeded with liver biopsy. And this is the H&E staining, which is a 10x magnification, and this is 20x, and this is the 40x magnification of the same slide, where we can see centrilobular coarse pigmentations can be seen. These are the centrilobular coarse pigmentations. And Fontana-Mason staining was done, and this is the 10x, 20x, and this is the 40x. Again, these pigmentations have been stained with the Mason-Fontana, and they are the centrilobular deposits. So the 12 portal tracts were present in that section and per section, and this showed a mild focal pigmentation with positive staining for Mason-Fontana. And staining for iron and copper was done, which was negative. There were no past positive globules, and there was staining was done with Mason trichrome, which showed no significant fibrosis. So diagnosis of Dubin-Johnson syndrome was made. Coming to the Dubin-Johnson syndrome, it was first discovered in high colored urine, ma'am. Bile salts and negative, ma'am. I mean, urine report is. Dubin-Johnson syndrome was first discovered in 1954. It is an autosomal recessive disorder. It was first discovered by Dr. Alec Dubin and Bernard Johnson, along with Dr. Sprins and Nelson. Both of these people, four people, they reported it separately. A total of 12 cases were reported in patients who present with chronic intermittent jaundice with no evidence of liver disease. And epidemiology prevalence is 1 in 1 lakh. But in Iranian Jews, it has got a prevalence of 1 in 1,300. Also in these people, there was a factor 7 mutation was also associated with them. But Dubin-Johnson will be having chromosome number 10 mutation, whereas in factor 7 mutation is seen in chromosome number 13. So there are two separate chromosomes are involved here. The genetic defect it is an autosomal recessive disorder which with a defect in the MRP2 transporter, which is present in the hepatocyte, canalicular hepatocytes lining the canaliculi with this MRP2. When it is defective, it is the main function of MRP2 is it helps in the transport of this conjugated bilirubin along with organic ions and certain drugs into the bile. So when there is a defective MRP2, which is coded by the ABCC2 gene, which is ATP binding cassette subfamily C member 2, this conjugated bilirubin will be transported out by the increased activity of the MRP3, and this comes out via the urine, causing the high colored urine. And a total of 15 mutations have been described to this Dubin-Johnson syndrome. 4 of these are splice site mutations, 6 are missense mutations, 3 are nonsense mutations, and 1 is a deletion mutation. Clinical features, patient will have only jaundice. Physical examination will be normal, although hepatosplenomegaly has been reported in few cases. And mild constitutional symptoms like nausea, vomiting, abdominal pain can be present. Pruritus is not seen. Clinical interest increases during episodes of intercurrent illness like viral hepatitis, or if the patient is using oral contraceptive pills, or during pregnancy, where again this drugs will be increasing the activity of, decreasing the MRP2 activity, further leading to increased jaundice. Animal models where Dubin-Johnson has been studied include the mutant corundale sheep and golden lion tamarin monkeys, and also 2 mutant strains of rats. Laboratory findings, serum bilirubin levels will be 2 to 5, although values as high as 20 to 25 have been documented. All other liver function tests will be normal. Prothrombin time will be elevated, will be normal, but in Iranian Jews, where there is a factor 7 mutation, prothrombin time will be elevated. Serum bile acids will be normal. Imaging studies, cholecystography shows non-visualization of the gallbladder, and biliary scintigraphy using technetium-99, lidophinin and disophenin in Dubin-Johnson syndrome shows a rapid, intense, homogeneous accumulation of the isotope within the liver without visualization of the intrahepatic biliary tree. Gallbladder will be intact and visualized approximately 90 minutes after the technetium injection. And also the isotopic activity increases, reaches the intestine within 1 hour of injection. Whereas all these things will be absent in Rotor syndrome. Histopathology shows black pigmented, gross anatomy shows a black pigmented liver, but the consistency will be normal and there will be no evidence of fibrosis, and there will be coarse granular deposits in the centrilobular zones. There will be lysosomal depositions, and these are composed of polymers of epinephrine metabolites. And during viral hepatitis, there will be complete disappearance of the pigments, and these pigments will reappear slowly after recovery also. Again, these are the centrilobular deposits which were stain positive with the Mason Fontana. And also the metabolism of organic ions like bilirubin, bromsulfathine, dibromsulfathine test, and indocyanine green, these are of historical importance, where bromsulfathine will be, the plasma concentration will be higher at 90 minutes rather than at 45 minutes, but these are also not diagnostic actually. Here this is a chart showing the bromsulfathine test that was used in Dubin-Johnson syndrome. A 5 mg per kg IV dose of bromsulfathine is given, and there will be normal initial plasma clearance, but later there will be regurgitation of the conjugated BSP from the hepatocytes into the plasma because of the defective MRP2. Coming to the urine coproporphyrin, normally in our body there will be 2 isomers, 1 and 3. The isomer that is normally present in our body will be isomer 3. In Dubin-Johnson syndrome, the total urine coproporphyrin levels will be normal, but more than 80% will be composed of coproporphyrin 1. Whereas in Rotor, the total urine coproporphyrin entirely will be elevated, but the 1 isomer will be elevated, but it will be less than 75% most of the times. And the treatment of Dubin-Johnson syndrome, actually there is no specific therapy, and reassurance of the patient is what is needed. And final slide that is showing the difference between Dubin-Johnson and Rotor, because both of them will be having conjugated hyperbilirubinemia. Dubin-Johnson was first described in 1954, whereas Rotor was first described in 1948. Both of them are having autosomal recessive pattern, and the serum bilirubin levels will be 2 to 5 milligram per deciliter in both, but it can go even up to 20 to 25 milligram per deciliter. And urine will be high colored in Dubin-Johnson, whereas it will not be that much high colored in Rotor syndrome. And physical findings, jaundice will be present in both, but hepatosplenomegaly has been reported rarely in Dubin-Johnson. Other LFTs will be normal, urine bile acids will be normal, and appearance of liver, there will be grossly black in Dubin-Johnson with coarse dark centrilobular pigments, and in Rotor it will be normal. And urine coproporphyrin levels will be normal totally in Dubin-Johnson, whereas it will be elevated markedly in Rotor syndrome. Both of them will be having isomer 1, with Dubin-Johnson 80% isomer 1, and in Rotor syndrome it will be less than 75%. Thank you. OATP 1B1 and 1B3. Yes. OATP 1B1 is.
I think these are some of the questions that they ask, okay? So you should know what's OAT1B1 and then MRP2 defect. And I think urine bile pigment is a very simple test. If bile pigment is positive, I would not have done anything. Yeah. That's all. And just get a, and we have done BSP, we used to do BSP tests. Yeah. We used to do it in 1978, 80s. So, and OCG, oral cholecystogram. Now you talk of scintigraphy, we used to do oral cholecystogram. That test would tell us the visualization of the gallbladder and on. So I think those are the things that are highlighted even in literature, the differences between the two. And I think, I don't know, would you do a liver biopsy? I would not have done it. I would not do it. It's
Maybe for an
harmless.
academic interest, you
No,
can do it.
All along, the patient is doing well. I would really not do it.
Just to demonstrate the black pigmented liver, you can do it for an academic interest. Because the approach is going to be a isolated, conjugated hyperbilirubinemia.
Yes, when the liver enzymes are normal, don't invite the diagnosis of hepatocellular jaundice. It's only a isolated hyperbilirubinemia.
Conjugated hyperbilirubinemia.
You have to list out the differential diagnosis for that.
Yes, sir.
I think the approach should be like isolated, conjugated hyperbilirubinemia rather than a hepatocellular jaundice for evaluation.
Yes.
Then that makes your approach easy. For an academic interest, you can always do a liver biopsy to show that it's a black pigmented
And
liver.
as Madam told, don't forget do the urinary test. Simple test to catch the diagnosis.
Sir.
We call the next speaker. Dr. Jaswant from Global Hospital is going to talk about roll-up power spiral enteroscopy in a case of obscure overt GA bleed.
Good evening, everyone. Myself, Jashwant from Global Hospital, and my mentor is Dr. Mahadevan, sir. Today we'll discuss a role of power spiral in small bowel bleed. First, we have encountered with a 39-year-old male patient with nil comorbidities presented to ER with episodes of passing maroon-colored stool since past 2 days, and history of giddiness and fainting were present. There is no history of hematemesis or no history of fever, no history of any NSAID intake or no similar complaints in the past, not associated with abdominal pain and also vomiting. So on examination wise, found to have pallor and tachycardia is present, and BP is around borderline 100/60, and other systemic examinations were normal, and per rectal examination found to have maroon colored stain. So he has been admitted to ICU and been resuscitated with the fluids and other supportive care. And once the labs were done, it was found to have HB of 4.4 and other parameters were normal. So he was transfused with 3 units of packet cells. Then repeat hemoglobin was 7.2 and stabilized. Then he had underwent upper GI endoscopy, which turned out to be the normal. And patient continued to be hemodynamically stable, and there is no further maroon stools. But hemoglobin we have monitored on the next day, it has been dropped to 6 gram. And as there is no further bleed, colon was prepared and planned for colonoscopy. So on colonoscopy, we have reached up to the terminal ileum, and there is no source of bleeding, no active bleed or no altered blood except for the presence of internal hemorrhoids. And CT abdomen was done with oral and IV contrast. There is no evidence of any extravasation or any other lesions. But on the subsequent day, he had again started to pass maroon stools with the further dropping of hemoglobin. So the diagnosis of small bowel bleed was made, and various options has been discussed with the patient to proceed for the further evaluation. So we have proceeded with the power spiral enteroscopy. These are the images. So that back side. So the upper one. So we can see the power spiral. Its length is around 240 mm, and the inner tube diameter will be 18 mm, and with the fins, the spiral fin diameter comes up to 31 mm. So based on the recommendation, that is the foot switch, and here comes the control. On the power, there is a force gauge is present. So this is the video presentation. According to the recommendation, due to the inner tube diameter is 18 mm, we have to dilate OG junction and then we have to proceed. So we can see the advancement of the power spiral. As we proceeded on reaching the terminal ileum, we found that there is sudden changing in the mucosa. From the normal villus pattern, they started to develop non-villus mucosa has been identified. And suggesting with the pit pattern on the NBI imaging, pit pattern with a gyrate pattern looking like that of gastric mucosa. And also there is an ulcer at the neck of the diverticulum. So these are the two. So we can see the clear-cut diverticulum can be seen along with the normal luminal. So we can, on the next image, we can see the ulcer present at the neck of the diverticulum, and the next slide is a lumen of the diverticulum. On the last image is the NBI imaging showing gyrate pattern of the gastric mucosa. So then he underwent resection and primary anastomosis, and the biopsy specimen also turned out to be having gastric mucosa with the gastric glands consistent with the Meckel's diverticulum. These are the histopathological images of the biopsy specimens showing foveal epithelium along with the gastric pits and glands. And as it is a true diverticulum, it has containing all the layers from the mucosa to the serosa. So small bowel source of bleed is very uncommon, and it accounts for only 5 to 10% of all GI bleeds. Of all causes of small bowel bleed, angioectasia is the most common. And these are the different causes of small bowel bleeding based on the age. Under the age of 40 years, we have to suspect either IBD, Dilophoid lesions, neoplasia, Meckel's diverticulum, and polypoidosis syndrome. Over the age of 40 years, again comes the angioectasia, Dilophoid lesion, neoplasia, and even drug NSAIDs, and very rare causes, HSP, small bowel, varicose, amyloidosis, those all things will be coming. So obscure GI bleed, previously the term obscure GI bleed has been used, which is defined as an uncertain cause of a bleeding even after doing OGD colonoscopy and the barium follow. It is further divided into occult and overt. Overt is, we can see the visible blood loss, whereas occult is positive fecal occult blood test will be present with or without iron deficiency. Now the term has obscure GI bleed is been replaced by small bowel bleed, which is now the obscure GI bleed has been reserved only for the patients where no source has been identified from the GI tract. So these are the algorithm in the ACG guidelines. So if at all patient presents with massive bleed, and if he is hemodynamically unstable, first resuscitate, then can proceed directly for CT angiography. If at all any positive thing is identified, we can refer the patient to the IR team and can do embolization. But if at all our patient comes into this category, presented with subacute ongoing bleeding but hemodynamically stable, so for them also we have to resuscitate. Then we can give the option of either going for video capsule endoscopy or CT enterography, which turned out to be, if positive, then go for the specific approach. So this we have proceeded with the enteroscopy. So this is the total overall algorithm. If at all suspected bleed, if warranted only, we can go for the relook endoscopy or the colonoscopy. Otherwise, we can go directly. If there is a suspicion of obstruction is there, first we have to go for CT enterography or MR enterography before proceeding for any video capsule. If there is no suspicion of obstruction, can go directly for the video capsule. Then if at all anything is found positive, we can go for direct intervention. So usually young patients with bleeding PR, we have to test with the capsule endoscopy, and followed by the, if at all it is negative, we can go for the Meckel scan. But it is a conditional recommendation and very low level of evidence is there. And if at all source of bleeding is identified by capsule, it is only a diagnostic, then we have to go for the other endoscopic therapy or any other therapies. So it is a strong recommendation. So after discussing various management modalities, we have given the option of the power spiral because it has both endoscopy as well as therapeutic value. In our center, since last 5 years, we have been evaluated for obscure GI bleed. We have done 5 Meckel scans, out of which only 2 turned out to be positive and 3 were negative. And even the studies have shown that negative Meckel scan can be seen in around 25 to 50% of the cases because it detects only the gastric mucosa. So Congenital diverticulum Meckel's scan is a congenital true diverticulum due to the incomplete obliteration of the vitalointestinal duct and the rule of 2. It is seen in 2% of the population and most commonly seen at the age of 2 years, and male to female ratio is 2:1, and it is a 2 inches long diverticulum found within 2 feet proximal to the IC valve and can be complicated in 2% of cases, and two types of mucosa ectopic tissue can be identified, out of which the gastric is the most common and the second one is the pancreatic. So on a histopathological examination, we can see the either gastric mucosa or the pancreatic mucosa, but the most common is the gastric mucosa, out of which ulceration can be seen in 75% of the patients, and the diagnostic scan is the Meckel's scan, which is the technetium 99 scan, and also can be diagnosed with the CT enterography or video capsule endoscopy or enteroscopy. So technetium 99 detects only the gastric mucosa and sensitivity of 85% with a high specificity 95%, but as I already said, it can be negative in 25 to 50% of the cases. It is further, the sensitivity will be reduced in the elderly age when compared to the children, because the elder ages the presence of the gastric mucosa is reduced.
Very exciting. Actually, even I have always thought, why can't we see the Meckel's diverticulum while doing a colonoscopy and all, but I know it's quite difficult to reach, but I think we have reached it. But only thing, in children, it's an easy diagnosis. Children we present with maroon stools, and we think of only Meckel's, and immediately we do. As you said, Meckel, I mean, per technique scan is very, very difficult. Sometimes twice we have actually been positive, and when the surgeon opened, it was negative. They couldn't find any diverticulum. So I accept, but anyway, this is a very, very costly test for a very, very simple. Generally, it is very common in children. That's why we have been used to doing it again and again. At least monthly, once in 2 months or once in a month, we will get a Meckel's diverticulum. So for us, it is too costly, I feel.
Nice presentation. How long did you take to reach
This
the
90 minutes it has taken, ma'am.
90 minutes? How do you assess
anterograde approach.
assess the depth of your enteroscope? How do you assess whether it's in the jejunum, the depth of the enteroscope?
Based on the villi, if the villi will be more prolongated, and also we have to reach the IC wall we can reach, ma'am. Yes, ma'am, CM we have used.
Or any measurements you use from the scope?
No, CM we have used.
Nice presentation. My doubt is now that both you and Dr. Nirmala also has said Meckel's scan may not be totally give a correct diagnosis. So would you put an enteroscopy higher up in the algorithm for evaluation of an obscure GI bleed?
Yeah, of course. We should not forget that. You should not go away with this message. Anyone who comes with a small bowel bleed, less than 50 years of age, Meckel's scan should be done actually. This should not go away with any patient with the power. I mean, if you have a power spiral, that doesn't mean that you should go with a power spiral. You should always do a Meckel's scan. But in given situation, actually real-time situation, if you do a patient comes with a bleed, then one more bleed, you do multiple investigation, relative may be anxious. Sometimes they will, when we discussing, they will ask like, what is the one test will give you a diagnosis or a cure? Then power spiral. So far, power spiral is a new modality. It has never been discussed in any one of these algorithm. And probably in future, if you start doing more number of cases, probably they'll include it. For example, previously we don't do endoscopy was not there and we rely on barium and other things. Now endoscopy and colonoscopy is available. Now power spiral has come. But Meckel's scan we should not forget. And the other important thing, we never seen Meckel's in endoscopy. That's the one thing. When we enter with the power spiral, we didn't expect Meckel's, but the power spiral directly enter into the diverticulum. And we saw something as unusual mucosa. Then we put an NBA that was a gastric mucosa. And we did a biopsy. Biopsy was not done. Then specimen also showed a ectopic gastric mucosa. The one thing is, Meckel's diverticulum should be considered in all small bowel bleed less than 50 years of age. And second thing, this is a very unique case. And we have just noticed in our power spiral. Thank you.
No need,
already we have proved it. No, pediatrics actually we need to 30 mm is a big one actually, very difficult actually. I don't,
No, ma'am, anterograde approach.
this was done through the we don't know the diagnosis. CT was negative.
How
so
much did you dilate?
we use generally 18 millimeter.
Okay, so you dilate.
The recommendation is 18 millimeter. Greco and the OG junction, but even without that you can go actually.
Actually, the guidelines, they say that you have to dilate, but that is for Western people. They said the esophagitis is very common. They have unidentified strictures. So they may have unidentified stricture and they will rupture and that will cause trauma to the esophagus. But here, there is no guidelines as such, but they say that if you have a dilator of 18 millimeter, you can dilate and do it. But we have done almost 100 odd patients with no dilatation and we didn't encounter much in the esophagus part. The problem comes in the duodenal part. So interestingly, Meckel's, we had 2 patients like this, incidentally diagnosed, and both were Meckel's negative patients. We did biopsy and proven gastric mucosa. They said it's a very costly investigation and it also comes with a risk partly. I mean, it's not very cool. You have to convince the patient for possible complication. And both of them was done through retrograde only. I have a feeling that the approach, when you come from above, you may miss the thing. Luckily, they have got through anterograde, but most of the time it's picked from retrograde approach. Yeah, maybe easier. 2 feet from IC valve. Yeah, it's 2 feet from IC valve. So if you have a suspicion, that will be the best choice.
So all cases you need to do a Meckel scan.
Yes, definitely. But there are sizable number of people who have Meckel's negative and you pick up with enteroscope. Pick up.
But whatever.
But for both these people, what I say is we have done a biopsy and proven that gastric mucosa from that part. Yes, the first one was sent by.
No, what was the diagnosis? What was the indication for doing power spiral in that case?
It was
due to bleed or due to
GA bleed.
GA bleed only.
This is an young man. I hope you remember this guy who's come, evaluated multiple transfusion, painless GA, massive GA bleed in a young man. Think about Meckel's first. If there is something else, I mean, will be next.
What's the role of PPA, massive dose of PPA?
So this chap, young man, who had a, yes sir, we thought he'll go for surgery, but I contacted him after 6 months to see how he has done. He said he didn't undergo surgery, he's not having bleed. I think he's just taking on PPA. I don't know. He didn't have a bleed.
Same gastric mucosa will attack this one.
Yes, sir.
Does that have a proton pump, individual proton pumps there?
Maybe there's a.
Of course, it should.
I'm not sure whether the proton pumps are there.
Must be.
Do the study.
Must be, sir.
1 or 2 case reports have seen they have tried PPI in gastric Meckel's. 1 or 2 studies are there, sir. Means they have said it is a temporary. Again, when we stop it, again the acid will release. Again, it will cause ulcers. So 1 or 2 studies are there.
I think the time is up now, so we'll go on to the next case. So next we call upon Dr. Krishna Kumar from Stanley Medical College to review the Indian literature of NAFLD.
Good evening, one and all. Today I will be reviewing Indian literature on non-alcoholic fatty liver disease. I am myself Dr. Krishna Kumar, from postgraduate from the Department of Medical Gastroenterology, Stanley Medical College, under the guidance of Dr. Manimaran sir. So these are the topics which I will be discussing today: epidemiology, the ongoing debate NAFLD versus MAFLD, NAFLD relation with metabolic syndrome, lean NAFLD, and how to assess, how to treat bariatric surgery, role of endoscopic bariatric liver transplant, and the summary. So before moving on to the topic, just a brief history of how the term NASH came. It dates back to the 18th century when in the 1836 a German scientist named Thomas Edison, he autopsied all the liver and he found that like some livers are weighing way heavier than the normal livers, and he retrospectively found those patients were taking alcohol. First he initially attributed it to alcohol, then later there is some progression by George Wood and Rudolf Virchow. They attributed this to like patients also have sedentary lifestyle and increased fatty food intakes. So they at the time coined the term fatty liver. Since then, World War, and there is little progression in the history of NAFLD. And in the year 1980, a scientist named Ludwig et al. From USA, Rochester. He biopsied 20 patients and he found that the histology is similar like alcoholic hepatitis, but all these patients were retrospectively not taking any alcohol. And at the first time in the year 1980, he coined the name non-alcoholic steatohepatitis. So moving on to the topic, globally, epidemiology, like globally, NAFLD is now the most common chronic liver disease with increase in incidence from nearly 25 to 38% in just a decade. And the global prevalence study, the most common prevalence is seen in Middle East and South American, but our Asian, it is nowhere lesser. It is also contributing nearly 27%. And then coming to the NAFLD prevalence in India, based on the various studies, it varies from 9% as reported in rural parts of West Bengal up to a maximum of 53.5% as reported in Chandigarh. So a large systemic review and meta-analysis by Shalimar et al. From AIIMS, which included 8 studies in children and 50 studies in adults, they found that the pooled prevalence of NAFLD in Indian population was 38.6% in adults and 35.4% in children, which is alarming. And the prevalence in children, majority seen in obese children. Whatever the studies till now we have seen all subjected to in-hospital bias. So only large community prevalence study available is from PGI Chandigarh from Duseja et al. They randomly screened 1,000 male healthy blood donors with ultrasound and they found every second patient had fatty liver with majority having mild steatosis and the median age was 34 years. The problem with this study is all were included were male patients, only 3 were female donors. So we can't generalize this statement in community level. So how about the severity of NAFLD? There is a common notion that NAFLD is a disease of mild severity. It no longer holds. A study by Rastogi et al. From AIIMS, they found that the percentage of patients having significant fibrosis at the diagnosis is more than 60%. So it is like NAFLD is not a disease of mild severity. More than 60% of patients have significant fibrosis at the time of diagnosis. So now coming to the ICON-D, Indian Consortium of Non-Alcoholic Fatty Liver Disease, a large prospective observational study, multicentric, carried out in India. As per this data, interim analysis, there is significant fibrosis at the time of diagnosis was seen in 36.3% and the cirrhosis at the time of diagnosis was seen in 11%. So coming to the next ongoing debate, NAFLD versus MAFLD. The term MAFLD was first coined by Mohammad Islam in the year 2020. Whenever patients having hepatic steatosis with either fitting into overweight, obesity or diabetes, they directly fit into MAFLD. But in normal weight or lean patients, there comes a criteria of metabolic syndrome to label as MAFLD. The reasons why MAFLD first came was NAFLD is just a diagnosis of exclusion. So lack of resources, lack of funds for further things, and also the term non-alcoholic in that word is trivializing the patient problem as per the data. So what do others and who and all endorse this MAFLD term is APASL, Middle East, Latin American, Sub-Saharan, Chinese, HEPAMET and Spanish registry. But what our Indian authors feel is, they found this is very premature and confusing also. A survey conducted by SP Singh et al. From Cuttack, Orissa, which included 150 patients, they found that more than 80% of patients were finding NAFLD is consoling, it didn't trivialize their problem. So recently concluded in a consensus, they concluded that the term NAFLD should not be changed to MAFLD at present as per Indian perspective. So coming to the next, NAFLD with metabolic syndrome relation. We all know metabolic factors contribute to the NAFLD, but it has a bidirectional link. NAFLD also over the course progressed to insulin resistance, diabetes and metabolic syndrome. So a Rotterdam study which included 2,800 participants, they found that the maximum odds of getting in the risk factor is central obesity, followed by diabetes, hypertension and dyslipidemia. The same thing as per our ICON-D interim analysis also shown that the commonest metabolic risk factor contributing to the NAFLD is central obesity, followed by diabetes, hypertension and dyslipidemia. And at least one metabolic risk factor is seen in 93% of patients of NAFLD. So whether this metabolic risk factors contribute to the severity, a study by Ryan et al. We found that as the metabolic traits increases, the percentage of degree of severity of fibrosis also increases. And phenotypically, as the traits increases, a study by Kanwal et al., they found that as the metabolic traits increases, the odds of getting HCC, odds of getting cirrhosis, odds of getting decompensation also increases. So to conclude, as the metabolic factors increases, the patients get the more severe disease. Coming to the next, lean NAFLD. The lean NAFLD, as per the systemic review and meta-analysis, which included 17 studies, they found that it is 11% in the general population and 25% among individuals with NAFLD. So the problem with this lean FLD data is whatever the data available globally and Indian also, it actually subjected to high variability. It ranges from 11% up to a maximum of 33%. So there is high variability as per the Indian lean FLD this thing. So our latest ICON-D interim analysis also shown that lean FLD prevalence is 10.6% in the population. So what is the significance of lean NAFLD is a study from ILBS, they included 336 subjects. They found that lean NAFLD patients have lesser degree of insulin resistance, lesser degree of diabetes, metabolic syndrome, lesser and fibrosis. So, the only pathogenesis which differs from obese NAFLD is lean NAFLD patients are predisposed to more genetic predisposition as compared to obese NAFLD. So to conclude, lean NAFLD has a relatively good prognosis with a higher genetic predisposition. So coming to the spectrum of NAFLD, we all know the steatosis, progressive steatohepatitis, cirrhosis, decompensation, death. During the early stages, cardiovascular complications is the most common cause of death. But as the cirrhosis sets in, liver-related complications are the common cause of death. Non-invasive assessment, how to assess hepatic steatosis, inflammation, fibrosis as per Indian perspective. Hepatic steatosis, we know the various modalities. A study published in European Journal of Radiology, they found that in the early degree of steatosis, clearly MRI and MR spectroscopy clearly performs better as compared to ultrasound and CT in differentiating the degree of steatosis. But the problem is MRI, fear of claustrophobia, and it is not easily available in our Indian setup in all the centers. So a study from Gyan Ranjan evaluated based on controlled attenuation parameter in transelastography, which included 462 patients, and definite cutoff, cap cutoff was for every degree of steatosis. And they found that in differentiating between steatosis versus no steatosis, it performs very good with a high sensitivity and specificity. But as the degree of steatosis increases, or else when differentiating between the grades of steatosis, it has very limited performance. So whatever the biomarkers we available in our setup, like fatty liver index, NAFLD fatty score, stato test, are all like needs validation and needs large scale screening before implementing in practice. And coming to how to diagnose steatohepatitis, the point to be remembered is ALT do not correlate with inflammation. Cytokeratin, a marker of apoptosis, correlates well, but it is not easily available in our Indian setup. The FAST score has been used to identify non-invasively with a RAS score of more than 4 when significant fibrosis, and this FAST score has been well validated in Indian population. My FIB score requires validation. So at present in steatohepatitis, our diagnosis is based exclusively on histology, but FAST score can overtake in future. This is a study by Arkady et al. From PGI Chandigarh. FAST score, he found that the FAST score performs well with a RX score of 0.8, and FAST score on comparing with other non-invasive parameters, it clearly performs better than other non-invasive parameters. So it has been well validated in Indian population. Coming to the markers of fibrosis, whatever the markers of fibrosis we have, like APRI, FIB4, ELF panel, everything, they have higher negative predictive value than positive predictive value. They helps in ruling out whether patient is having significant fibrosis or not. They don't tell exactly the grades of fibrosis. So degree of fibrosis are present solely based on biopsy, but the non-invasive markers we can differentiate whether patient is having significant fibrosis is there or not. So the various non-invasive markers of fibrosis we know, I will be discussing in the upcoming slides. They have very good sensitivity and specificity in ruling out whether significant fibrosis is there or not. So coming to the main part, NAFLD risk stratification. This is as per the Western data. any patient coming to your clinic in the community level with imaging evidence or with the metabolic risk factors or ALT abnormalities, after ruling out other causes of steatosis, we diagnose him as NAFLD. We start suspecting him as NAFLD, and then like how to rule out whether patient is, as per Western data, they consider advanced fibrosis rather than significant fibrosis. In this advanced fibrosis, they rule out by NFS score or FIB-4 score. If it is low score, they will regularly follow up. If it is intermediate score, they will go for imaging modalities. If it is high risk, they will consider liver biopsy. This is as per Indian data. That's by Western data. But what our Indian data differs from them is, when any patients we consider rather than F3, we consider F2 fibrosis. The reason which I will be telling in the upcoming slides. And instead of NFS and FIB-4 index, we used APRI and FIB-4. And the cutoff we use for ruling out significant fibrosis is FIB-4 less than 1 and APRI less than 0.45. The why the specific cutoff, which I will be telling in the upcoming slides. So as per Indian perspective, any patients coming with this abnormalities, when we start suspecting NAFLD, first we want to rule out F2 rather than F3 fibrosis based on this specific cutoff. When it is low risk, we will just usually follow up. When it is intermediate risk, there we go for other imagings like either transient elastography or MR elastography. Then if we don't perform liver biopsy in all patients, we perform liver biopsy only if there is discordant results between APRI, FIB-4 or imaging things. So this is the Indian protocol. Any patients coming, and when we start suspecting fatty liver, we just calculate FIB-4 APRI. If it is low risk of significant fibrosis, this will just routinely monitor. If it is high risk, then we do for a transient elastography. If LSM cutoff is less than 8, just to advise lifestyle intervention. If it is between 8 to 13.6, there rolls the NASH specific pharmacotherapy. And if it is more than 13, manage in the lines of cirrhosis. The reason why I told F2 fibrosis rather than F3 is a study by Parambir Dulai et al. They found that like the all-cause mortality and the liver-related mortality increases from F2 itself rather than F3. And the study from Sanyal et al. In NEJM, published in NEJM, they found that incidence of cardiac events and non-hepatic cancers were similar across all the stages. As the liver-related mortality increases from F2 itself, and the incidence of cardiac events were similar across all the stages, as per our initial guidance, it suggests F2 itself to be significant rather than F3 fibrosis. And why the cutoff less than 1 and FIB-4 and APRI less than 0.4 in ruling out significant fibrosis is, this is a study from Shamir Shah et al. They found that they compared FIB-4 with biopsy. They found that FIB-4 less than 1 has a very good sensitivity of 100% and specificity of 94 in ruling out significant fibrosis. And another study from Kohli et al. They also found APRI less than 0.4 has a good sensitivity and specificity in ruling out significant fibrosis. So now in the tertiary level, whenever patients comes, how to diagnose NASH-related cirrhosis, whether liver biopsy is needed for all patients as per Indian perspective. As per the AASLD guidelines, it requires liver biopsy in all the patients. But what our INASL suggests is, any non-invasive marker suggesting of cirrhosis with the history of metabolic risk factors, and after ruling out other etiologies, we can label him as NASH-related cirrhosis. So what the non-invasive test as per the INASL suggests is, there are multiple non-invasive tests for diagnosing NASH-related cirrhosis, APRI, FIB-4, NFS and LSM. But on comparing, they found that the non-invasive markers APRI, FIB-4 have modest performance, not very good performance. So at present, INASL suggests LSM cutoff of 13.6 as the definitive cutoff to detect the cirrhosis, not the non-invasive markers. So what the lifestyle intervention, what you will advise to your patients in NASH-related cirrhosis, we know there is a dose-dependent relationship between the degree of weight loss and the percentage of NASH improvement. As the degree of weight loss increases, like more than 7%, NASH resolution starts. When there is more than 10% weight loss, fibrosis regression will start. So based on this, our NASL suggests target weight loss of 7 to 10% is recommended in patients with NAFLD. But the next question comes is whether to go for intermittent fasting or daily calorie restriction. As per now at present, INASL suggests to daily calorie restriction of less than 30% or 500 to 1000 kilocalories with limit the intake of fats and limit the intake of free sugars. But what is the role of intermittent fasting? Yes, definitely intermittent fasting has a definitive role. There are multiple observational studies are there. No RCT is available. Multiple observational studies like time restricted fasting, alternate day fasting, everything have proven benefit. But there is no like advantage of one over the other. Till now, no studies have been there. And apart from the weight loss mechanisms, they have advantage through weight loss independent mechanisms also. So at present, intermittent fasting definitely has a role. Most of the studies, the issue is small size, observational in nature, no RCT. But the latest, only one RCT is available, published some 1 or 2 months back in the China. They found that intermittent fast, 45 patients included in time restricted this intermittent fasting and daily calorie restriction, and randomized, and they followed up for 6 months to 12 months. They found that there is no significant change in intrahepatic triglyceride content in both the groups. So at present, it is too early to call intermittent fasting as advantage over daily calorie restriction or these things. So INASL suggests daily calorie restriction at present to follow. So what is the role of exercise? Our INASL suggests moderate intensity aerobic or resistance exercise at least 30 to 45 minutes per day in 5 days as per the cardiology guidelines. Next question comes to you is whether to perform aerobic or resistance exercise. This is a study published in 2017 in Journal of Hepatology. This is actually a review article. They found, included multiple studies, they found that on aerobic and resistance exercise, there is no significant change in differences in ALT level or intrahepatic lipid percentage. So based on this study, what our INASL suggests or what our Indian data suggests is go for aerobic exercise in all patients, but resistance exercise, those who have poor cardiorespiratory effort or those who cannot perform aerobic exercises go with resistance training, as both have the similar advantage, but resistance training has less energy consumption as compared to this thing. So other things about diet, Mediterranean diet, there is a role, but it is really difficult to follow in our setup. So the issue with the lifestyle intervention is a study by Romero Gomez et al. Published in JHEP in 2017. They found that the percentage of patients achieving more than 7% weight loss and the percentage of patients achieving more than 10% weight loss is only less than 10%. And the percentage of patients sustaining this also less than 10%. So there comes the role of NASH-specific pharmacotherapy. At present, NASH-specific pharmacotherapy, our INASL suggests only in liver biopsy, strong evidence is liver biopsy proven NASH with F1 to F3 fibrosis. But as we can't go on liver biopsy in all patients in our setup, we can non-invasively do with a significant fibrosis, but it is a weak recommendation. Pending further evidence, INASL doesn't suggest pharmacotherapy in NASH-related cirrhosis. So based on the various studies and based on the international societies guidelines, our INASL suggests to use 3 drugs at present: vitamin E, pioglitazone and saroglitazone. So first I will be discussing the drugs. So this is a landmark study, we all know, PIVON study, where 247 patients were randomized 1:1:1, vitamin E 800 international units and pioglitazone 30 mg, and they were followed up period of totally 96 weeks, and they found that vitamin E significantly improved steatosis, ballooning, inflammation. There is more than 2-point reduction in NASH score. It achieved the primary outcome, and based on other further multiple trials meta-analysis, definitely based on this, INASL suggests vitamin E has a role in NASH resolution, but there is the only issue is it doesn't improve fibrosis scoring. So coming to the pioglitazone, although didn't meet its primary endpoint, it decreases the steatosis, flobular inflammation, ballooning, but the percentage of patients resolution of NASH achieved is significant in pioglitazone. Based on this study and another study where is pioglitazone 18 months, it is randomized, 100 patients were randomized and followed up. They found that there is definitive improvement in NASH score with pioglitazone. Based on these evidences, our INASL suggests vitamin E and pioglitazone can be used in NASH, but it has no effect on fibrosis scoring at present. The problem with the PIVON study is it is all performed in non-diabetics, but pioglitazone further it was evaluated in randomized in other studies, diabetics also, and it has proven beneficial. So coming to the saroglitazone, as per the evidences 2 study, which included 102 patients, had carried out a 10 sentence in India, which included NASH with F1 to F3 fibrosis and randomized in 2:1 saroglitazone 4 mg and placebo. They found saroglitazone had a significant improvement, nearly 52% of patients in saroglitazone group had a significant improvement as compared to placebo. In this study also, saroglitazone has no, whether it didn't worsen fibrosis also, it didn't improve fibrosis also, but there is a NASH resolution achieved based on this study. But saroglitazar recent study published from Kolkata, but it is a single center study by Sarjit Chaudhary et al. They found that they used saroglitazar. Advantage of study is they used both diabetic and non-diabetic, included 63 patients. And another advantage of study is they included in compensated cirrhosis patients also. So saroglitazar, in this study they used in compensated cirrhosis also. They found that saroglitazar improves the NASH score also, it improves the fibrosis score also. But all based on non-invasively, not on histologically in this study. That is one flaw of this study. Another is like it is very less sample size in the F4 group to call it. So it is too early to call the use of saroglitazar and compensated cirrhosis group. So how to select a drug in NASH patients? Any patients coming with metabolic risk factor and cost effectiveness also you want to see. If patient is having metabolic risk factor and patient is affordable, go for saroglitazar. And vitamin E is a low cost, easily available, but it should be avoided in patients who are having CA, prostate, hemorrhagic stroke risk patients. Pioglitazone, try to avoid in cardiac patients and those who are at risk of CA urinary bladder. So coming to the pediatric NAFLD, very less drugs are available. Like tonic trial, vitamin E has been studied. It improves the NASH ballooning, but it has no effect on liver fibrosis. Metformin also extensively studied in pediatric. It improves the ballooning, inflammation, but it didn't improve the fibrosis. No other drugs extensively evaluated are proved beneficial in pediatric NAFLD or NASH. So coming to till now what we discussed is about NASH specific pharmacotherapy. Now any drugs having role on fibrosis improvement. This is a landmark study, Flint trial by obeticholic acid. The Intercept Pharmaceuticals, they carried out in 287 patients. They found that obeticholic acid, 25 mg, significantly improves the fibrosis and NASH resolution also it helps. So based on this Flint trial, next Regenerate trial was carried out in 2,400 patients, where 1:1:1 randomization, obeticholic acid 10 mg and 25 mg was carried out. They found that obeticholic acid 25 mg has significant improvement in fibrosis as compared to 10 mg and placebo. And the rate of adverse effects like pruritus, increase in LDL were more or less similar in all the groups. So based on this thing, FDA has approved the role of obeticholic acid in fibrosis improvement, but still pending further evidences like INASL still yet to approve obeticholic acid in fibrosis improvement. So coming to the NASH related cirrhosis, obeticholic acid has been tried in NASH related cirrhosis reverse trial where 920 patients were included. Recently I saw the study is completed and the press release has been given by pharmaceuticals, but no interim results or results have been, paper is available for that. They found that they didn't meet its primary endpoint. And another study, as I recently discussed, saroglitazar in the cirrhosis, in 11 patients it has proved beneficial, but we need large scale and RCT trials before implementing in practice. And there are multiple retrospective studies, vitamin E improved and metformin in NASH related cirrhosis, it improving the overall mortality and decreasing the HCC risk, but all are retrospective data. We need prospective and RCT trials large scale before implementing in practice. So coming to the role of future pharmacotherapy, weight loss drug semaglutide has been recently extensively used. They found that semaglutide 4 mg significantly 0.4 mg significantly improves the resolution of NASH, but there is no effect on liver fibrosis. And the next study, semaglutide recently published in NEJM, they tried in compensated cirrhosis also. It has no benefit in compensated cirrhosis. So how to monitor the response to therapy? As per Indian perspective, we can't do liver biopsy in all the patients in NAFLD. So based on the secondary outcome from Flint 2 trial, they found that ALT decrease at week 24 more than 17 international units has been associated with a favorable outcome of NASH score reduction of more than or equal to 2 points. So based on this, our INASL suggests ALT decrease more than 17 units can be used non-invasively as a marker of this thing. And how long the duration, based on the available trials, PIVANS trial and evidences trial, at present vitamin E and pioglitazone should be used for a minimum duration of 2 years and saroglitazar for a minimum duration of 1 year. So now coming to the management of comorbidities, statins are not contraindication in NAFLD or NASH. Statins are contraindicated only in patients with decompensated cirrhosis. But overall, there should be a holistic approach in managing the entire thing rather than focusing only on liver-related morbidities. So coming to the role of bariatric surgery, there is no RCT available till date for bariatric surgery. So bariatric surgery, like at present, not recommended as this thing. But patients' weight loss per se indication is there. We can go for bariatric surgery in non-cirrhotic and compensated cirrhosis, but not in decompensated cirrhosis. Why? The reason is in this study they have found that decompensated cirrhosis patients had 16% mortality if they undergo bariatric surgery, whereas non-cirrhotic and compensated has less than 1% mortality. And another study by Agarwal et al. From AIIMS, they also found that bariatric surgery significantly improves the stenosis, lobular inflammation, ballooning, and NASH score. But we need a large scale and RCT trials for bariatric surgery. So coming to the role of endoscopic bariatric surgery, whatever the endoscopic bariatric surgery data available is all either retrospective or limited small data. So this intragastric balloon carried out in India, only totally 8 patients were done intragastric balloon. Only 5 successfully underwent LDLT post this thing. Intragastric balloon in this study has been used as a modality prior to LDLT for improving the graft weight ratio. Another duodenal mucosal and endobarrier all tried. They are all retrospective data only. So we need prospective and RCT trials. So coming to the transplant perspective, at present, NASH is clearly the definitive leading indication of cirrhosis transplant in India. And as per the Rela Hospital data, the 5-year survival rate for NASH-related cirrhosis is lesser, for 76%, as compared to viral hepatitis, which is 87%. So this is in contrary to the UNOS registry. So to proudly finally to say, our India is the first country to include NAFLD into non-communicable diseases program. To summarize, globally our NAFLD is an increasing trend. At present, as per Indian perspective, NAFLD only holds, not MAFLD. And like for in liver biopsy, don't go for on all patients, only in selected patients. And how to restratify any patients coming, first you should restratify based on APRI and FIB4 non-invasively with a FIB4 cutoff of 1 and APRI of 0.45. Once we rule out significant fibrosis, in our data we take F2 rather than F3 fibrosis. And lifestyle intervention I have discussed, and NASH specific pharmacotherapies are available, and we need further large scale trials of other studies. And overall it is a holistic approach rather than focusing only on NASH related complication or cirrhosis related complication. You need to more focus on cardiovascular these things also. So these are the ongoing trials. That's it. Thank you. Thank you for giving the opportunity, and I'm going to answer the question.
Nice presentation. In this literature, Indian literature, which aspect is worrying you?
Which aspect is, for me it is worrying is pediatric NAFLD is an alarming rise.
Because it's been
like for more than, like as per the data, 35%. And globe, yes ma'am.
So what is the reason for that?
Actually
because
more
they don't
of
have
now,
an underlying diabetes. Have they done any studies to say which is why it is increasing?
reasons quoted are more of westernized diets we are following.
No,
but
in which group of like socio-economical or rural or urban?
Ma'am, urban population and more of westernized diets only have high risk of pediatric NAFLD as per whatever available data I saw, ma'am.
To the pediatricians, what control measures you can do for children, because it's very difficult to advise them on diet or weight restrictions.
Yes, actually, it's a good evening, everyone. It's a good question. And after the post-COVID, we are seeing a lot of obese children, madam. The pandemic of obesity and NAFLD has come more. And actually, what we advise is mainly lifestyle modifications. And most of the children, they watch TV, they use mobiles, they don't play. The main is a thing, enormous weight with a sedentary lifestyle. And what the parents also, the practice is a Western type of diet. They eat more of junk food. So we concentrate more on the diet and the exercise rather than anything, madam. And some of the children has even gone for developing diabetes, insulin resistant type of diabetes. The endocrine, actually the private setup, we refer a lot of obese patients with diabetes nowadays, especially in the post-COVID. So we use only vitamin E, madam, especially in children, along with diet and exercises and play and avoiding this.
Do they follow the diet restriction?
It's very difficult only, madam, but we have to tell the parents, and they are worried nowadays because once they develop diabetes. So after developing all these complications, Their parents are now, they are able to accept the importance of diet and exercise. And most of the children, in the morning time, they have to rush to the school, they don't have the time. And in the evening also, they have peer pressure and lot of things they have to concentrate more on studies, they don't find time. And the indoor type of your lifestyle, staying in flat also is another important contributing factor. So we are seeing a lot of patients now, madam.
Swiggy and Zomato.
Yeah, madam, that's what. They order online with the telephone.
I think it's going to be a holistic approach.
That's
We need
what.
to educate the parents rather than the children.
Parents and the grandparents in pediatrics.
That's what. So we need to educate
That's
the parents
one.
more and more about the importance of diet and lifestyle
Right.
modification so that they can
I do not know
inculcate all
why
these.
the outbreak is now a lot of patients. 90s and 100 kgs even at 10 years of age. Junk food is the main thing. And they eat lot of processed food, madam. Processed and fast food nowadays.
I want one observation. This is slightly away from the topic. We have to educate the doctors, especially the diabetologist. They concentrate on the diabetic foot, kidney, eye, but liver is most dangerous. As per the Verona study, is 4.2 is the cutoff. There's 2.7 for the kidney injury, 2.2 for other injuries, whereas 4.2 for the liver injury. They take fatty liver as just face value, doesn't give importance. So they are seeing the diabetologists, they are seeing more cases. India is a diabetic capital, unfortunately. We are progressing wrong things, we are progressing. Population, diabetes. So we have to concentrate and you have to work with the, I suppose the society can have a session with the diabetologist and gastroenterologist, a combo. This was what I advocated during Ravati Madam's superannuation talk. So this make a difference because government cannot do. We have to go make the government to do something. So you see a combo with gastro and diabetologist because we are seeing more than 20,000 cases of OP cases. If we can pick up the cases, then that's the only way we can reduce. Otherwise, children, obviously, children cannot correct. We can't correct the mother. In children, they say, when recurrent abdominal pain in children, we have to correct the mother. Similarly, if you correct the parents, automatically children will get corrected. Thank you.
Hello. Here. I have two suggestions.
Yes,
You said circulators are maximum duration, the minimum duration is 1 year, but as per literature, the safety zone is 1 year. It is not as a minimum or maximum. Circulators cannot be given more than 1 year because all the studies are restricted only to 1 year.
1 year, yes.
And the same thing again, the pruritus increases with the dose of obeticholic acid. If you are giving 25 milligram, pruritus is high. If it is 10 milligram, it is less. But 10 milligram, therapeutically, it is not going to be good. But the companies are marketing only 10 because of the risk of pruritus.
Sir, but the regenerate trial, it concluded that like between 10 mg and 25 mg, definitely 25 mg had relative risk is high, sir. But it is not statistically significant increase in the risk of side effects, pruritus as compared to the 10 mg group, sir.
Dr. KRP asked me to make a couple of comments. First, a very good presentation. I think all of us are encountering patients who are worried they got fatty liver and they come and tell you in hushed tones. So what I do is I reassure them. I tell them, your passport is Indian. So in India, more and more people now have fatty liver. Relax. So the question is, why is it that it is increasing so much? Do you think one generation ago, people were eating less or active more physically or both? The problem is, those who are all older are turning nostalgic. So we think, maybe I ate less or maybe I ran around more, etc. So it's to see, or was it not getting diagnosed? Was it all along there and not getting? It is not clear. In fact, I have posed the same question to Ajay Duseja, who is focusing on this area. He is also not sure, I must say. There is no good data to say what was the prevalence 30 years ago. We do not know that really. I tend to think it's more of diet. We are eating more than probably one generation ago. But no one knows that. Yet another point is, 10% or 30% in India have lean NASH. Now one of the drugs you mentioned has weight gain.
It's a pioglitazone.
Pioglitazone. So there is lean NASH and pioglitazone. So maybe that's an opportunity to try the drug, but there is no data like that. So it's unknown. We do not know how to deal with this, and it's still an evolving epidemic. Thank you.
I congratulate on behalf of our team all the postgraduates and the institution for their wonderful presentation. Thank you.
Thank you. Thank all the chairpersons for starting this session and all the presenters. I request the team from Stanley to write it up as a manuscript and submit it to our journal. I think the last time MMC has done their work on IBD and they have submitted as a manuscript. Hopefully this comes up as a routine so that we will be able to get, all this hard work that has been put by the postgraduate transforms into some good literature review that we can publish, and that will also improve the visibility of the journal where they'll be able to download and there'll be more hits of it. So I thank all. I think it's my pleasant duty here again that in this last 2 months, last month we didn't meet because of a summer vacation. I think now we have got an opportunity to congratulate all of some members who have been awarded and things. First, I think adding one more feather to the cap, Dr. Jayanti has been awarded as the first Dr. Sarvapalli Radhakrishna Award. May I request Dr. Raghuram to felicitate Madam Dr. Jayanti with the shawl, please. Thank you. I think she's been a great teacher, and we hope there will be more who will follow that. I think Dr. Muhammad Ali had an endowment ovation last week at the MMC, and here I think Dr. M.S. Revati has just completed her tenure as a dean at Omandrar Medical College and superannuated last month. We again congratulate her, and may I request Dr. Epan to felicitate her. And it's a proud moment that a gastroenterologist has been appointed as a Vice Chancellor of Tamil Nadu Medical University. And I think it's a proud honor for us, and hope we'll be able to work with them in the future as a society to move forward in the academics and research. So moving on to the current thing, only ongoing multi-center study right now that we have is Plex study that is going on. As an effort, probably I think what I would propose is we should form more special interest groups. I think there have been a lot of interest among the endoscopy group, which they want to focus on, and they move on so that we can have some focus on some research question, conduct a multi-center study, or maybe make a registry out of it, and then proceed. I think one of the best examples that probably we should look up is Dutch pancreatitis group. They have owned the space in the last 20 years. Maybe we may not come to that level immediately, but I think that's a good start point. So I hope that in the next few months, we will start off with some focused area of interest. It's open to all members, but probably few should take the lead and frame research questions, and we move on and take the registry forward. Maybe some could be on liver, on IBD, on advanced endoscopy. I think the chance is open for all of us to take it forward. The other thing that I request is that, there are many publications from members of our society, but probably we ourselves don't get to know about it. So my request will be to send that, whenever it gets accepted for publication, please send in a mail to the secretary TNISG@gmail.com. We can display it in our monthly meeting so that develops more interest among us, particularly for postgraduates, for them to go and back and read what is happening in our own setting. So that will also tell us, instead of collecting it once a year for a purpose of awards, I think it will be a good practice to see every month what has come up. It may be case reports, it may be literature, it could be a original manuscript for publications, it could be a review. I think it will be very nice for us to know what is happening every month. So it's a request to all the members if they can send up a mail to us. And the other option that we discussed last time, probably in a month from now, probably in August or so, probably we will have online CME that will start off, particularly to give opportunity to postgraduate students who are studying in colleges apart from Chennai. There are many places where the DM and DNB has started off, probably Madurai, Salem, Coimbatore, and so many places, where they get opportunity only in their national or in the midterm ISD conferences. So probably we will start off an online CME, apart from the one that we do as offline right now here, probably once in 2 or 3 months, and see how it goes, so that it gives them an opportunity for them to go. So we'll be working on it, and I'll be getting back to you shortly. The key forthcoming meetings and dates that you need to look at is probably next week we'll have our National Endocon at Indore. The midterm ISG will be on 23rd and 24th of September at Pondicherry. ISG Con is on 21st to 24th December at Bangalore. And I request all the postgraduates to send in their abstracts. I think the last date is on July 15th for National ISG meeting. And the next annual Tamil Nadu ISG meeting will be on 10th and 11th of February at Madurai. And one small request, since the Tamil Nadu Medical Council requests us that we send our attendance as a form on a Excel sheet, I request that, we have our display boards which give us the QR code. You can scan it using your mobile phone, and it's a Google form which will take less than 1 minute for you to fill up. It will ask for your T1 Medical Council registration number, your full name, email ID, and phone number. You can just upload it so that it becomes easy for us to send it to the Tamil Nadu Medical Council. And QR codes have been placed in all of the tables. You can please use it so that it becomes useful for us. And it is easy for us to follow it up. Thank you so much for your time. I now go on to request the chairpersons for the next CME to take the stage and conduct the proceedings. I request Professor Badmanabhan and Dr. Bharat Kumar to conduct the proceedings. Thank you.
Good evening to each and every one of you. At the outset, we thank the organizers for giving us an opportunity to be here. Now, the clinical examination and the conventional stool examinations are on the brink of extinction. It is a very pungent fact. But anyhow, today we are talking about the conventional stool examination. Is it relevant in current clinical practice? Professor K. Prem Kumar from Department of Digestive Health and Diseases will enlighten us. Let us see what he is going to say. Prem Kumar, please.
Respected chairpersons, teachers, friends and dear PGs. For a change, I usually used to talk and end in all our ISG forum. Today I've been made to talk in between, and the credit goes to Dr. Pirama. A couple of weeks ago, Dr. Pirama called and asked me, can you give a talk? I was a bit reluctant, but I had to agree to talk. And when he gave me the topic, I was very reluctant, but I had no other option but to talk on this topic. As told by PP sir, conventional stool examination is really not being done nowadays. I think even when we in our clinical practice, we just look for occult blood rather than the other things in stool examination. Probably we have more advanced techniques which will probably help us in diagnosing help in diagnosis of the stool examination. And in fact, asking the patients also to collect stools, and then if you ask the patients, most of them, when they come to us and ask about the stool color. I think many of them tell that they don't look at the stool color, especially when they defecate in the Western toilet, they just flush and without looking at the stool color. I used to tell the patients that looking at the stool color will give us a lot of information regarding the problems you have. So, with a short background, conventional stool examination, is it relevant in current clinical practice? So, learning objectives include introduction, advantages of stool examination, collection of stool samples. How do we collect? Because it's very important. Because we in practice we just sit and write and give, and then we don't know how the patients collect the stool sample. That is very important. Microscopic examination, macroscopic examination, and finally chemical examination. So coming to the introduction, based on the Western literature, normal amount of stools in adults is about 200 grams per day. But in the Indian population, according to a study conducted by Dr. R.K. Tandon et al., it is around 310 grams. The stool composition includes, mostly it is made up of water, around 75% of it is made up of water. The rest is made up of indigestible residue, undigested food which is digested but not absorbed. Apart from that, it contains bile, epithelial cells, secretions from the GI tract, mucus and bacteria also. What are the advantages? As you all know, examination of stools aids in the investigation of GI disorders. It helps in detection of parasites, evaluation of dysentery, comparison between amoebic and bacillary dysentery, investigation of helps in enteritis, evaluation of chronic diarrhea, and chemical examination, especially will evaluate for anemia, looking for stool occult blood, fecal fat excretion in patients with malabsorption, and uromelanogen. How do we collect the stool samples? Very important, because we tell, and then as I told earlier, because most of the patients don't know how to collect the stool samples. In general, a random specimen of freshly passed stool is collected in a clean, dry, wide mouth container with a tight fitting lid, and it should be transported to the laboratory immediately. Or if you use a toilet, we can ask a person to have a clean container below the toilet seat and collect the sample, and tell the patient to pass the stool specimen directly into the container, or to pass on a stool or on a piece of paper and transfer it to the container using an applicant stick. I very well remember in our town, and people used to collect the sample in a matchbox, and then the stools used to be passed not in the container. They used to pass the stool on the floor and then collect and give it in those days. Hope this presentation gives an eye-opener so that we can tell our patients. And what is the quantity of stool which you normally ask the patient to collect? About 1 inch of formed stool or 15 to 30 ml of liquid diarrheal stool is needed, and the smallest amount being 2 to 5 grams. And when you look for the parasites, they are best detected in warm, freshly passed stools, which should be examined as early as possible, preferably within 1 hour of collection. That should be emphasized to the patient, which normally we don't do. And you should make sure that stool should not be contaminated with urine, water, soil, or any other contamination, because urine and water destroy trophozoites, and soil will introduce extraneous organisms, and it also which hinders the proper examination of the stool. And if there is a delay in the examination, then probably you should refrigerate the stool, or a fixative can be used if specimen is to be transported to a distant laboratory. 10% formalin or polyvinyl alcohol are some of the preservatives commonly used. And make sure that if you want to have a correct result, we should at least collect 3 separate samples at 3-day intervals, especially in parasite detection. You should know that one negative report for or parasite does not exclude the possibility of infections. What are the other general precautions we normally take? We should tell the patients before collecting the stool sample. Usage of mineral oil, bismuth compounds, antibiotics, antacids, and kaolin material and barium. All these things should be avoided because they interfere with the examination. And if any of the above has been used by the patients, it is preferable to ask the patient to wait for a couple of weeks before a stool sample is collected, unless there is an urgent indication. What are the number of samples to be collected? Before we started therapy, 3 samples on alternate days, but the gap should not be more than 10-day period. And the positivity rate is about 50% with a single specimen, which goes up to 90% in 3 specimens. What will happen to post-therapy specimens? Usually 3 specimens are collected, and when you treat a person with protozoal infection, these 3 specimens should be collected 3 to 4 weeks after therapy. When you treat a patient with helminths, it should be done 1 to 2 weeks after completion of therapy, and with tinea, it should be 5 to 6 weeks after the completion of therapy to check for the eradication. And coming to the macroscopic examination. In general, we have to look at the consistency of the stool, color, odor of the stool, and whether there is any blood or mucus in the stool, and at times presence of worms or segments of tapeworms. Now, coming to the consistency, cysts are likely to be formed in formed stools. Trophozoites are most likely to be found in loose or watery stools or in stool containing blood and mucus. So it is better we take the sample from these areas to look for trophozoites. And trophozoites should be examined immediately maybe within 1 hour of passing, because they die soon after being passed in the stools. Examination of the formed stools can be delayed, but it is better if it is completed within 24 hours of collection. In general, based on the consistency, we can make a diagnosis like dry and hard stools can be seen in chronic constipation. Ribbon-like stools can be seen in malignancies, especially the rectal problems and strictures. And Bristol stool chart is very important. In fact, nowadays the recommendation will be to have a chart in the table where we consult, because it is better we show the patients and ask them how the stool consistency is. According to the studies, in Indian population, predominantly type 4 Bristol is the common thing present. Coming to color, normal it is brown in color. If it is black and tarry, it indicates upper GI bleed. And if it is black, it's commonly due to drugs and like usage of iron salts and bismuth, because with the advent of anti-H. pylori therapy and emergence of resistance for all the other organisms, now bismuth is being used commonly. And red color stools in tumors and lower GI bleeding, red currant jelly stools in intussusception, clay colored stools in biliary tract obstruction, and silvery stools in ampulla of Vater CA. Watery stools can be seen in infectious organisms, rice water in cholera, unformed blood with mucus plus commonly seen in IBD and bacillary dysentery. Pale stools with greasy appearance is seen in pancreatic deficiency. Odor, at times we can make a diagnosis by asking the odor to the patient, but it's difficult. And what about the presence of mucus in the blood? Small amount of mucus presence in the stool is normal, but if it is in large quantity and if it is associated with blood and mucus, it is abnormal. It's commonly seen in colitis and IBS and severe constipation. And what about the presence of blood and mucus in stools? It is seen in cases wherein with patients with inflammatory bowel disease and bacillary dysentery, and also in patients with GI malignancy, lower GI malignancy. The most important thing is microscopic examination. Normally, what are all these are the following things which you see in the microscopic examination of a stool: leukocytes, red blood cells, macrophages, epithelial cells, bacteria, ova, cyst trophozoites, meat, muscle fibers, and fat. I'm sure that most of the stool reports from the lab will contain most of the factors here, which when we look at the reports. And where do we see leukocytes? Normal stool may contain occasionally about 0 to 1 leukocytes. To look for leukocytes, the smear should be prepared from area of mucus or watery stools, and it is not seen in diarrhea which is caused by viruses or parasites. And it is not sensitive in the diagnosis of inflammatory diarrhea. And if you see leukocytes in the blood or in the stool sample of a patient with diarrhea, it is better not to give antidiarrheals. It is commonly seen in patients with bacillary dysentery, IBD, shigellosis, and various invasive infections, and abscess, and even in amoebiasis also. Red blood cells are seen in cases of dysentery and hemorrhoids. Macrophages are seen in patients in stools of patients with bacillary dysentery and ulcerative colitis. Epithelial cells are seen in inflammatory conditions of the bowel. Fat is present in patients with malabsorption or maldigestion. And at times, meat and muscle fibers in stools will also be seen. Their presence indicates impaired intraluminal digestion, and it is commonly seen in malabsorption and maldigestion. How about ova, cysts, trophozoites of parasites? Normally, none should be seen. And to rule out parasitic infections, you should examine multiple stool samples. As indicated earlier, a negative report in one sample doesn't rule out an infection. And at least 3 consecutive day samples should be examined to definitely rule out a parasitic infection. When it comes to giardia, we look for trophozoites and cysts in the stool. When it comes to entamoeba histolytica, demonstration of trophozoites is the diagnostic marker for amoebic dysentery. When it comes to the carrier state, we look for cysts in the stool. And what are the differences between amoebic and bacillary dysentery? In amoebic dysentery, the cellular oxidates will be scanty, red cells will be seen, macrophages will be few, and trophozoites, motile trophozoites will be seen in large numbers with ingested blood cells. And then in bacillary dysentery, the exudates will be more, and pus cells will be numerous, and bacteria will be present. When it comes to coccidia, demonstration of oocysts of human intestinal coccidia, such as Isospora, Cryptosporidium, and Cyclospora, can be seen. They are seen in direct wet mounts of stool with modified Ziehl-Neelsen stain, oocysts stain uniform red-pink. With the advent of a lot of immunocompromised individuals, these things have become common nowadays. When it comes to roundworm, diagnosis by demonstration of eggs in the stool, eggs to be demonstrated in direct wet amount. Occasionally, adult worms can be seen in stool. When it comes to hookworms, once again, identification of hookworm eggs in the stool examination in a direct wet stool, wet amount of a stool sample. When it comes to tinea, identification of the eggs, identification of the gravid segments of proglottids, or at times identification of the scolex for the diagnosis. When it comes to strongyloids, the diagnosis is by demonstration of the rhabdidiform larva in the fresh stool specimens. Eggs are rarely seen in the stool. When it comes to whipworm, pinworm, identification of typical eggs, and the most important thing is the taking of anal swab in patients whom we suspect pinworm infestation. And we should not forget about the artifacts, because these artifacts can mimic OVA resist and interfere with the diagnosis, and they will be confused with the OVA, various protozoa and helminths like yeast, fungus, plant fibers, and we should not forget about air bubbles also. The word about stool culture. Stool culture is commonly done to identify bacteria associated with enteric infection. Do we do cultures in all patients? No. According to the ACG recommendation, stool cultures are recommended in patients with severe or persistent diarrhea, and in bloody diarrhea, and patients who have temperatures of more than 38.5 degrees Celsius with diarrhea, and if there is presence of stool leukocytes, lactoferrin or occult blood, maybe we have to ask for a stool culture. According to IDSA, if the diarrhea has been there for more than 1 day with bloody stools, and if the patient has got associated fever and dehydration, and if there is evidence of systemic illness, then we ask for a stool culture. Apart from these two things, the most important, other important role for stool culture is public health, wherein we'll have to identify the isolates, especially when there is an outbreak. So for what is the sample size for stool culture? For liquid or a soft diet, it's approximately 5 ml. If it is formed stool, it will be about 0.5 to 2 grams. Specimen collection should be done under strict aseptic techniques, and the transportation should be done in a proper media. And early processing, preferably within 2 hours, is the ideal thing to have a good result. And if there is a delay, it should be refrigerated, and preferably obtained prior to the initiation of antimicrobials. And at least 3 stool cultures collected on separate days are recommended if the patient's clinical picture suggests bacterial involvement despite previous negative cultures. And how to collect the stool culture? Some studies have revealed that culture of patients who are hospitalized for more than 3 days, the outcome is poor. So you'll have to be careful in patients who are hospitalized, and probably you should restrict stool cultures for patients who are being treated as outpatients, or patients who have been admitted, and they should be inpatient for less than 3 days. There are certain exceptions to this rule, especially in patients with HIV, severe neutropenia, and suspected nosocomial outbreak. We can break this rule. And coming to the occult blood examination, which is the common examination which I asked for in the conventional stool sample, it is used to test the presence of occult blood, and you all know the various causes of occult blood in stools, and it is recommended as a screening procedure for detection of asymptomatic colorectal cancer. The principle is hemoglobin has peroxidase-like activity and releases oxygen from the hydrogen peroxide, and we use various modalities to detect the presence of oxygen molecule. And guaiac-based tests are currently used because the other tests like benzidine and orthotolidine are not used because of their carcinogenic potential. How do we collect the sample? Sample should be, in one sample, it should be taken from different areas because the blood will not be uniformly distributed in a particular sample. And apart from that, because of intermittent bleeding, it is better we do the stool sampling on 3 consecutive days to confirm the presence of fecal blood. And there are, you should be aware of causes of false positive tests and false negative tests. Injection of peroxidase containing foods like red meat, fish, poultry, vegetables like turnips, radish, cauliflower, cucumber can interfere, causing false positive tests. And drugs like aspirin and other anti-inflammatory drugs can also interfere, causing false positive tests. Where do we get false and negative tests? Foods containing large amount of vitamin C, and intake should be limited to less than 250 milligrams or for at least 3 days prior to testing. And it has been found in studies that we have been taught that we should avoid certain foods and medicines prior to doing fecal blood. But according to studies, cooking vegetables at 100 degrees Celsius for more than 20 minutes, in fact, inactivates plant peroxidase, so that we don't have to kind of avoid these vegetables during fecal blood testing. And gastric acid denatures plant peroxidase. So people with normal gastric secretion, we don't have to worry about stopping these food materials. Apart from that, ingestion of more than 750 grams of peroxidase-rich food only interferes, and it is not practically possible to take such a large amount. And a povidone solution, antiseptic solution, can cause false positive result. Toilet sanitizers can interfere with the guaiac-based stool fecal blood testing. Similarly, steroid, iron preparations, and anticoagulants to be avoided, but however studies have shown that low-dose aspirin need not be stopped prior to testing for fecal blood. And a few word about malabsorption of fat. Test for fecal fat is qualitative and quantitative. Qualitative is stool examination by Sudan 3 stain. A random specimen of stool is collected after putting the patient on a diet of more than 80 grams of fat per day. This is easier compared to fecal fat is quantitative fecal fat estimation because you need to collect the samples for more than 3 days. And the sensitivity is 77% and the specificity is 98%. And acid steatocrit is a simple, inexpensive test, and it's more reliable. Sensitivity is 100% and specificity is 95%. And here you can measure simultaneously fat, nitrogen, and carbohydrates in a single sample. When it comes to quantitative examination, which is not being done nowadays because you'll have to take more than 70 to 100 grams of stool for at least a week prior to the testing, and should collect samples for 3 consecutive days, and they should be every day it should be refrigerated, and it should be sent to laboratory. And more importantly, such a huge amount of stool sample, the laboratory technician should be really think for him to examine the stool sample and give a proper result. So probably we can go and look for, I think it's more of a theoretical thing rather than a practical thing now. Values more than 7 grams per day is abnormal. Values more than 14 grams per day is specific for fat malabsorption. And sometimes values up to 14 can be seen in volunteers who take more laxatives and whose stool weight is more than 1000 grams per day. Test for urobilinogen, it is determined by Ehrlich's aldehyde test. It should be, a sample should be fresh. And when it comes to reducing sugars, Benedict test is the solution with the test which is being used. If the value is less than 0.25 milligrams, it is normal. If it is more than 0.5 milligram, it is abnormal. Trypsin and chymotrypsin we used in those days, it is not being commonly used. Fecal chymotrypsin is diluted in the presence of concurrent diarrhea, and you should discontinue PERT therapy before we do this fecal chymotrypsin. Stool electrolytes are used to assess electrolyte imbalance in patient diarrhea. It should be evaluated along with serum and urine electrolytes. And fecal osmotic gap to differentiate between osmotic diarrhea and secretory diarrhea. And fecal pH below, fecal pH below 5.6 is characteristic of carbohydrate malabsorption. Coming to the reference range, The bulk stool, according to Western literature, is about 100 to 200 grams. Indian literature is about 300 grams. The color is usually brown. Water is up to 75%. pH is 7 to 7.5. RBCs are absent. White base cells is few. Epithelial cells, few cells will be there. Calcium oxalic crystal and triple phosphate crystals are not seen. Fat should be less than 7 grams per day. Fat droplets average 2.5 per high power field in random sample. Urobilinogen should be around 50 to 300 milligrams in 24 hours. There should not be any no parasites should be seen in the stool, and no ovocytes or trophozoites should be seen in the stool. Concluding, stool tests give us very useful information for the physician and diagnosis. With advent of newer tests, there has been improvement in the sensitivity and detection rates of various components of stool examination. However, conventional stool tests still hold a value in the diagnosis of certain conditions like parasitic infections and fecal occult blood, etc. And they stand time tested. Thank you.
Thank you for your exhaustive and informative talk. The topic is open for discussion.
Sir, he is going to talk.
Dr.
Arun is going to talk.
By Dr. Arun.
It's only conventional stool samples, sir. Other tests will be talked. It's only conventional.
I think we'll let Prem sir off the hook. I'm going to call Dr. R.S. Arun, a consultant from Madras Medical Mission, to talk on recent advances in fecal tests for GI infections and utility in clinical disease.
Good evening, respected teachers and dear friends. In the next 30 minutes, our discussion is going to be about the newer tests, fecal tests for diagnosing GI infections and how we can integrate them in our routine clinical practice. So as gastroenterologists, we are fairly confident in managing chronic diarrheas because the management protocols are standardized. However, in cases of persistent and recurrent diarrheas, we face a lot of dilemmas in our routine practice. So in order to set the tone for discussing the newer fecal tests for diagnosis of GI infections, I present two clinical scenarios. So the first is a patient who is a 15-year-old boy who presented with diarrhea, diffuse abdominal pain and vomiting since last 4 days. And it was like a large volume watery diarrhea, 6 to 8 episodes per day without any blood or mucus, and 1 day history of fever associated with chills. He was started elsewhere with Taxim and given 4 doses. And he presented to us with the following findings: very high counts and neutrophilic leukocytosis, and all the other parameters appear to be normal. And we have done all the tests which Prem sir has mentioned: stool cultures, looking at parasites, blood culture, etc. And even look for other viral tests in the serum. So despite all this, we were not able to make a diagnosis. So we have started the patient like we usually do with injection of ceftriaxone, and since his counts were not coming down, we added azithromycin also. So as you can see, the patient continues to be symptomatic, having the abdominal pain and jaundice on his 5th day also with persistently high counts. So what do we do in such scenarios? So we'll come back to this case once we discuss the test which we do in such circumstances. Another is a case which is a 51-year-old male with diabetes, hypertension and chronic kidney disease, history of Behçet syndrome in childhood and vasculitis related nephrotic syndrome at present, referred from nephrology with 4 to 5 episodes of watery diarrhea in last 2 months. So here he intermittently improves, but gets another episode, and he is having a history of steroid treatment for his nephrotic syndrome related to vasculitis. And in the last episode, he was treated by the nephrologist with IV ceftazidime because they detected Citrobacter in the stool culture. So now the patient has presented to us with another episode of diarrhea, asking for a solution. So this is another common dilemma. These are, I'm sure most of us would have come across patients like this. So now, how do we deal with these kind of dilemmas? So this is where the role and utility of newer tests for GI infection come. And that is what would be the next part of our talk. So we will deal with why these newer tests are relevant and what are the unmet needs which make them relevant, the changing paradigms in the way we look at stool tests, and we can group the recent advances in fecal diagnostics under 3 headings, that is fecal biomarkers, fecal antigen tests, and molecular fecal tests. And now the new kid on the block is the GI multiplex PCR, and we will examine their relevance and role as well as clinical utility in our routine clinical practice. So how do we integrate these tests into our routine practice, and what are the take-home messages? So now, are these still relevant? So we heard that there is a waning interest in stool tests among physicians. However, this is the closest real-time reflection of intraluminal gut milieu, and the sample collection is not technician dependent. So it is also suitable in special populations such as children, elderly, and the differently abled people. And it is a point of care or on-field test which can be used to evaluate rapidly acute diarrheal outbreaks. So they still have relevance, and we have seen 2 scenarios where we don't have any solutions. So in this context, there are still a lot of unmet needs. So we need the fecal test to give us a rapid solution, help us identify a specific target to treat, and help us rationalize the use of antibiotics in this context. It should be cost efficient and applicable in resource constrained settings. So the traditional approach to fecal tests was identification of pathogen using morphological characteristics and culture methods. The contemporary approach involves antigen detection and DNA extraction, and using panels which can detect multiple organisms in one go. So now the recent advances in fecal diagnosis have happened in 3 broad areas. First is the fecal markers, second are the fecal antigen tests, and finally the fecal molecular diagnostics. So now fecal markers, for example, fecal calprotectin is something which we all know and use frequently in cases of inflammatory bowel disease. However, these are general markers of inflammation. So when we look at those specific to GI infection, there are hardly any which can be used for this purpose. There are some molecules in the pipeline which may have a potential role in diagnosis of GI infection, but most of the fecal biomarkers which are available now or are in development are in the areas of inflammation or in the carcinoma detection. So the ones with potential use in GI infections include eosinophil protein X. So this is a protein secreted from the eosinophils when the lamina propria of the gut lumen is injured, and it is mainly a marker of eosinophilic activities, useful to diagnose eosinophilic disorders as well as disorders where parasites are involved. So another is a neutrophil gelatinase associated lipocalin. So this is secreted by neutrophils, and it is a marker of inflammation, but also shown to be increased in bacterial infections. Cathelicidins are another class of proteins secreted by neutrophils, keratinocytes, and epithelial cells of GI tract. They are useful for diagnosis of shigellosis and other bacterial infections, but they also are being evaluated as a marker of inflammation rather than a specific marker for any organism. So coming to the antigen test, the most well-known test is H. pylori stool antigen test. So this has been in practice for a long time, and it is useful for making the diagnosis as well as to confirm eradication. It has a very high sensitivity and specificity, and the monoclonal enzyme-linked immunoassay is similar to urea breath test. However, there should be caution exercised in ordering this test when there is use of antibiotics in the preceding 4 weeks, PPIs in the preceding 2 weeks, and bismuth compounds in order to avoid false negative results. So fecal antigen test for H. pylori is, has a sensitivity and specificity of over 95%. It is slightly below the gold standard of urea breath test. Another underutilized fecal antigen test, especially in the context of community level outbreaks and in the pediatric population, is rotavirus stool antigen test. So this test, while PCR test is the most sensitive, the easier to use is ELISA and latex agglutination method. And rotavirus can be detected 1 to 2 days before the onset of clinical disease, and can be detected up to 4 days after the onset of symptoms. In addition to these, newer tests have come mainly for adenovirus stool detection, and where the ELISA has a sensitivity of 78% and a specificity of close to 100%. Giardia stool antigen test, which is very important because this is one pathogen which we often find it very difficult to confirm in cases of persistent diarrhea, and entamoeba stool antigen test, which can distinguish between the pathogenic entamoeba histolytica from the commensal entamoeba dispar. Another is a Clostridium difficile toxin antigen test. So toxin B is what is clinically important. The C. difficile related disease caused by A toxin alone has not been observed. However, the enzyme-linked immunoassay combining measurement of both these toxins gives a better result than measuring toxin B alone. There is a chance of high false negative test because 10 to 100 to 1000 picogram of toxin should be present for the test to be positive, and the false negative rate is higher in children. So the current recommendation for testing Clostridium difficile is to use nucleic acid amplification test, which have a high negative predictive value, and if it is positive, this detects the gene for toxic production, and if it is positive, we can do the antigen detection using enzyme-linked immunoassay for toxin production or toxigenic culture. So now coming to the molecular fecal diagnostics. So what do molecular fecal diagnostic mean? So they are basically the methods to extract genomic sequence, DNA signatures of various organisms in the stool specimen. So we have to, the steps involved include fresh sample collection, preservation requires special precautions, and transportation also has to be standardized. Then next step is DNA extraction, which can be done by either conventional PCR or RT-PCR, and finally molecular analysis using RFLP technique or DNA sequencing. So now the important aspects in specimen collection include using commercial fixatives, which is what is practiced in the West. And if that is not possible, stool can be collected in a clean vial and frozen. And while transporting, it should be either refrigerated or shipped with dry ice. Formalin is not recommended as a preservative. And when commercial fixatives are not an option and stool needs preservation, it can be mixed with potassium dichromate or absolute ethanol and shipped refrigerated. One of the advantages of molecular fecal test is the detection of parasites, especially microsporidia, which is otherwise very difficult to detect and used to be detected by electron microscopy earlier. And in addition to that, in immunocompromised patients, checking for cyclospora, etc., have also become easier with the availability of these tests. So now, going one step forward, multiplex molecular panels have become available, which have enabled the detection of numerous pathogens, more than 20 bacteria, viruses, parasites, etc., in a very short turnaround time of less than few hours. So this has led to significant impact on patient management in reduction of time to first identification of a pathogen and changing patient outcome by early initiation of therapy, altering the antimicrobial stewardship, the rational use of antibiotics, and optimizing infection control, person to person, spread by early identification and treatment. They are also useful in special situations such as immunocompromised states and can help differentiate acute graft versus host reaction from infectious etiology, especially in patients who are in the post-transplant setting with immunocompromised state. So now, which are these GI multiplex PCR panels which are available? So this is an article which looked at all the data available till 2021 on these panels, and 37 studies were finally included in the analysis. So now it found that there are 7 approved FDA approved GI multiplex PCR panels. And if we look at all these panels, the first one was approved in 2013, and within next 6 years till 2019, we have another 6 more. And they all have a turnaround time of less than 5 hours. So when we compare these different panels, what we can see is that there are panels which are which have a large number of organisms, such as the Luminex panel and the BioFire film array panel, which can detect bacteria, viruses, and parasites. And this BD-Max Enric panel has 3 separate panels available for bacteria, parasites, and virus. The virus one is yet to be FDA approved. And there are also panels which look at specific groups, enteropathogens, or any in immunocompromised settings, etc. So there are 7 of these available panels. And the one which is most popular and easily available in our country is the BioFire film array GA panel. So this can detect 22 organisms. So the bacteria such as Campylobacter, Salmonella, Shigella, various E. coli, Vibrio, Yersinia, and Clostridium difficile, which pretty much covers most of the spectrum we see, and parasites such as Cryptosporidium, Entamoeba, Giardia, and Cyclospora, as well as norovirus, rotavirus, adenovirus, astrovirus, and sapovirus. So this test is available since last few years, and it costs around 10 to 15,000. And there are head-to-head comparisons available for 2 of these panels, and this shows that compared to Luminex GI panel, the film array GI panel performs little better for most pathogens other than rotavirus. And all these panels perform better than the conventional stool test. So what are the benefits of using these multiplex panel tests? Faster turnaround time, improving the workflow, and beneficial in critically ill patients where rapid diagnosis and treatment is important, early cessation of antibiotics when not indicated, higher sensitivity and specificity across a broad range of organisms from a single specimen. And however, they have a lot of limitations. One, the initial investment is high. Another key thing is that a PCR test cannot identify between a living and dead organism. So the presence does not always means that it is a causative organism. And another shortcoming is that without identifying and extracting the organisms, we are unable to do antibiotic susceptibility testing or to further characterize these organisms. So now, what is the yield of these panels in various settings? So this study I have taken to highlight that if this test is used as a screening test in a normal adult OPD for patients with uncomplicated diarrhea, our yield is likely to be only around 20%. That means the number needed to get a positive result is at least 5. So if we order 5 tests, we are likely to pick up a relevant organism in one patient. And many of these patients are common organisms like E. coli, norovirus, and Campylobacter and Salmonella. So if used without any pre-test selection, then the yield of this GA multiplex panel is low. So compliance with IDSA guidelines could reduce testing in a lot of patients. And while interpreting the GI multiplex PCR results, we need to use a lot of clinical judgment because positive isolate equates whether it equates to presence of a living organism needs to be determined clinically. And detecting incidental carriage of bacterial toxins may not always be reflective of active infection. And within endemic regions where there is known GI colonization of microbes, the use of these PCRs might prove to be of lower utility. So this is of particular significance in tropics and countries like ours, where there may be fecal carriage of a lot of organisms, just like H. pylori. So it may not make a clinically useful addition if we rely on this test alone to decide the treatment. So now, what about the cost benefit analysis? Is this going to be a costly affair, or does the cost get justified? So there is only a retrospective study available to look at it, which looked at this, and what it found is that though the test cost is high, the cost of hospitalization, the additional cost of antibiotics and investigations are minimized, and thereby there may be a justification for using these in appropriate clinical settings. So now, what do the guidelines say? Unfortunately, there are no prominent guidelines which I could find in the last 5 years. So the earliest guidelines which is there is AGA guidelines, where they recommended use of culture independent methods of diagnosis as adjunct to traditional methods, but it didn't specify in which scenarios they are useful. In 2017 IDSA recommendation, they described the situations where it has a clear benefit. They are in the immunocompromised setting and patients who have fever, abdominal pain or blood in stool. The latest guideline which I could find is Korean guidelines, which may be applicable to our part of the world. So since traditional stool tests often cannot identify pathogens responsible for acute diarrheal diseases, consider the molecular diagnosis. So they recommend the use of molecular diagnostics in fecal molecular diagnostics in the setting of acute diarrhea. And since panel-based multiplex molecular analysis detects DNA regardless of survival of microorganisms, so use clinical judgment to interpret these results. So use it, but interpret with caution. So now, summarizing what we have just mentioned, what are the areas where we could consider using GI multiplex PCR panels? The clear indication seems to be diarrhea in the context of immunocompromised state and in acute diarrheas which we see in post-transplant recipient patients, wherein the drug levels also play an important role, and this may be a useful addition to exclude infections. Another important aspect is decision to use antibiotics. So we all know that the bacteria constitute only 15% of acute diarrheal syndromes. However, we use antibacterials in 50 to 60% of patients. So this antibiotic use can be minimized by rational use of these multiplex panels and investigating a potential outbreak. And some of the scenarios we mentioned where the stool culture is negative or where there is a previous antibiotic use. So these are the potential areas where we should consider integrating GI multiplex PCR panels. So now, what are the future developments expected? Newer multiplex assays can report CT values. So we have seen this in COVID times. So this PCR detects the DNA and whether it is significant, whether it is an active infection, that we were relying on CT values. So similarly, they are trying to incorporate CT values to determine active infection. And another area where multiplex PCR has not been adequately studied is in the context of chronic diarrheas. While GI multiplex PCR assay has faster turnaround time, more studies are also needed to see whether using this changes the clinical outcomes. And in tropics, this article looked at all the commercially available multiplex panels and found that none of them are completely suitable for use in tropics. So which means that even for us it may be true. And there is a call for using a tailored approach based on the local epidemiological data and development of customizable cartridge-based point-of-care GI syndromic PCR panels, which means it should be a portable thing which we can carry to the field and get an answer itself. So the ideal next generation multiplex nucleic acid amplification test is envisaged to be a small, portable and self-contained unit which can be used for an individual sample and not for a large batch of sample. And it should be capable of performing sample preparation, molecular processing and data analysis as well as reporting results. It should be made cost effective for its use at a community level. So to conclude, overall the GI multiplex PCRs appear to be here to stay, and the challenge is to optimize it to use to improve outcomes for patients and workflows tailored to local epidemiology, being cognizant of costs of testing. And a word of caution that it should not be overutilized in self-limiting cases of acute gastroenteritis, as this may lead to increased healthcare costs without really improving the patient outcomes. So now,
thank you very much, sir. You have given a very well balanced.
Sir,
no.
You can, I think.
No, I just wanted to say, if we have time, whether we can have a audience view on the cases, what they would do in such scenarios. So it may be useful to hear from our seniors and teachers how they would approach these two cases which I presented as a dilemma.
Sir, one more doubt. In our COVID pandemic, you didn't talk about RT-PCR of coronavirus.
Yes, yes.
you didn't touch upon this role of RT-PCR and COVID, I guess, coronavirus.
Only the fecal test we dealt with, sir. We did not use the serum.
No, RT-PCR of fecal.
For corona,
Yeah.
COVID. Actually, there are some panels which have coronavirus also, but most of these panels, if you see, were developed till 2019. So when this was not a problem. So the commercially available and FDA approved panels do not have coronavirus in it.
That is where our country was missing, sir. Jan 14 of 2020, China released an article. In order to differentiate the COVID, and the patient is cleared, they should do RT-PCR of feces to get them free from isolation. Our country missed that part. That's why I asked you.
So this case one, about a 15-year-old boy with a diarrhea of 4 days and fever of 1 day and history of antibiotic use for 2 days. And this patient has a persistently high counts, which is a neutrophilic leukocytosis, and all the other parameters being normal. The culture, viral test, parasites, and all were negative. Procalcitonin levels were 33.68. And post-treatment it dropped down to 7.23. However, the counts did not come down, and patient continued to have symptoms. There was a mild clinical improvement only in this case. So we actually thought that it could be Salmonella or Campylobacter, and used ceftriaxone, added on azithromycin when there was no clinical improvement. So what do we do next? This patient is continuing to have high counts and the symptoms are persisting. Should we just wait or use one of these tests, newer tests? Okay, this may be one situation where it is useful. Actually, we don't have much experience with it, but it could be a scenario. Oh, okay, sir.
How did you manage?
So the patient actually now we have we didn't once the counts have stabilized, we are just waiting on him. We are waiting for it, but we don't know what happened. Actually, there is an ultrasound also which we have done, which shows some ascites and a thick gallbladder, acalculous gallbladder, which a GB wall thickness of 9 millimeter.
The picture fits into an enteroinvasive organism because it's causing diarrhea as well as septicemia in this.
Yes.
Been enteroinvasive E. coli?
Sigma does to be indicated in this.
Actually, I looked up the guidelines, sir. The guidelines don't recommend scopy in acute diarrhea settings.
Obviously, there's going to be some inflammation inside. That doesn't throw any light upon management.
So the second case also, a patient with vasculitis and having recurrent diarrhea. It's not a continuous diarrhea, but multiple episodes coming in within 2 months. So this patient, one issue is that the nephrologist has treated a culture based organism, that is Citrobacter, which we usually don't see as a cause of. Is there any background of steroids? So should that Citrobacter be treated or?
Intermittent course of rifaximin with liquid probiotic.
What about want to do the aspirate, jejunal aspirate and check out bacterial overgrowth?
Bacterial overgrowth, okay.
On breath test.
If required.
Yes, ma'am.
Rifaximin with probiotic.
Another thing is Clostridium difficile testing, which also. So this also we thought it may say a case which could, where GA panel could be useful. So now.
Thank you, Dr. Arun. Thank you, chairpersons. It's a time to thank everyone. Thanks Patton, who has been the cornerstone in organizing this meeting. And thank to the office bearers, president of TNISG, and chairperson, speakers, and the postgraduates who presented 3 wonderful cases. So there are a lot of things to learn from them. And the final 2 talk on stool test, the conventional test and advanced stool examination. It was very informative. And to the attendees, please check and kindly scan the registration. That will help us to get you CME credit hours. So there is a new rule, so you have to do it. So whoever has not scanned it, please scan and fill out the Google Forms immediately. So we had good time today. I'd like to thank Delvin for organizing and Residency Towers for the ambience and the audiovisual team. And thank you all. We can proceed to dinner tonight. Cocktail dinner. Thank you all.